and it is abdominally coated with a drug and it is crimped onto the balloon, all by machine. However, in this technology, how they do abdominis coating is they first crimp the stent onto the balloon and then they do the coating. What is the difference is that it's not only the abdominal surface is coated, the exposed part of the balloon in between the stent studs are also coated. In short, it becomes a combination of DES plus DCB. And they do fusion coating, that is, not only the stent but the exposed part of the balloon is also coated, so that the entire length of the lesion is coated with the drug, so that there won't be any geographical miss. Then edge coating, 0.5 millimeter, both edge of the stent is coated with a drug. This will take care of the edge restenosis. And the combination of the biodegradable polymer plus this drug forms a biodegradable film, and there's a unidirectional release of the drug into the vessel wall, so less chance of microembolism and drug loss. So in abdominal stent, we have got the stent coated the abdominal surface, plus the exposed surface of the balloon is also coated. So it is actually a combination of a DES plus DCB. Now, where are the evidences? We have got the enabled registry. It is a multi-centric Indian registry. Mainly the principal investigator was Dr. Samir Dhani. There are almost 2,500 patients, of which 860 patients were diabetic. And there is an overall net clinical outcome. The MACE at 3 years, at the end of 3 years, is green is only 3.6%. It is generally MACE is about 5 to 6% at the end of 3 years. So that the other parameters which we look when we implant the stent. Look at the outcome in diabetic patients at the end of 3 years. MACE, it is 5.3. Again, it is less. Generally, it is 6% most of the stents. So it is found to be beneficial and promising in patients with diabetes mellitus. There are ongoing studies, enabled 1 enabled registry, dedicate registry by Lucas Testa, and ability RCT by Antonio Colombo, and ability DM Global. Ability DM Global is a world's largest RCT against abdominal stent, that is the sirolimus eluting stent versus everolimus eluting stent in diabetic patients. There are 20 countries with more than 100 sites involved in the study. So it is a drug which has the on-label indication of for patients with diabetes mellitus and acute MI. And then it's a very, very trackable stent. Now this is a very tortuous RCA. The operator has taken a Judkins right, and you see the stent easily slips in, dilated and okay. Now this is a very tortuous circumflex, almost a right angle at the origin, and you will see how the stent tracks. It's a long 28 millimeter stent. It tracks very nicely and then deployed nicely. So very, very trackable stent with optimum radio opacity. Now, 2 cases where this other abdominis that I shown the trackability of the stent is a very trackable stent, and this is a patient with juxtaosteal 90% LAD stenosis, and we implanted a DES using OCT guidance, and this was done in 2017, and we had done a repeat angiogram in 2022. It remains well. There is maybe 10% restenosis there. Very good result after 8 years of implantation. And this is again another patient which is a 67-year-old lady diabetic with an osteoproximal LAD. Again, we put a stent from left main to LAD, again under OCT guidance. This was the result. This was done in May 2023, and we had done a repeat angiogram at the end of 8 months because she was going to US. They wanted absolute sure, though we had done a repeat angiogram. This shows that it has an excellent result in diabetic patients. In conclusion, advances in DES design and technology improve PCI outcome. Abdominis is a novel DES with a unique NV solution technology which makes it practically functions like a combination of DES plus DCB. So it is 2 in 1. It acts like a DES plus the balloon acts like a DCB. This makes it better suitable for diabetics with encouraging and very promising outcome data. It's a very trackable stent with optimum radio opacity. Thank you very much for your attention.
Thank you, Dr. Suresh, for the wonderful talk. One small doubt. So when you're dilating these stents, because you've got a DEB in between, you dilate for a longer period, like for example in DEB, you need to have a little more time.
Yes, excellent. Ideally, you have to keep it for 1 minute. or at least 45 seconds. We keep it for 1 minute if the patient can tolerate.
Actually, that is the way in abluminous stent is actually to be inflated for minimum 60 seconds to get the optimum result, because you have a two-way of coating of the drugs are there, number one. Number two, it is available for the last 4.5 years and we use in multiple, one of the most trackable stent available in the market. The stent is actually very trackable. Whenever there is a difficulty to take a stent down, usually, earlier I think Delhi Orsiro was the most trackable stent, and now I think Orsiro availability is very less problem. So I think I take these stents for many complex lesions, but I get a very good result. And this technology is very important. You should have a way of drug elution, and for that you should have a 1 minute inflation. Most of the people inflate for 15 seconds and 20 seconds and then finish it off. That is why some of the patients may have a wrong result. Actually, I was part of the study with Samir Dani. Excellent result created in diabetic population. I think we'll go to the first talk of Rajneesh Kapoor. Rajneesh is given more duty because he is available only 1 day. No, next time we should make him available for all the 4 days.
Well, thank you. So I was given this assignment of talking about diabetic potential and how we should have a better stent for a diabetic.
Can you change the timing?
Maybe 20 seconds for me. Okay. Okay. So diabetes mellitus.
12 minutes.
Okay. So diabetes is a big challenging subset. We all know while we deal with such patients of coronary artery disease because of multiple reasons. So if we look at the volume of diabetics in the world over, I think by 2035 more than 500 million population will be diabetic, and India is a diabetic capital of the world. And similarly, diabetics, they have more morbidity and mortality, and once we deal with coronary artery disease, plan a PCI, we also encounter a lot of stuff in diabetic patients. So having said that, this is my question, that do we experience any limitations of our current generation drug-eluting stents in managing diabetic patients undergoing PCI? I think the answer would be yes with most of us, that still we require that more ideal stent in specifically diabetic subsets where chances of in-stent restenosis, where chances of stent thrombosis is higher than non-diabetic population. So limitations of current DES in diabetes, I would say, would be the delayed vessel healing due to slow endothelization, increased inflammatory response. So that this practically translates into focal restenosis, edge restenosis or diffuse stenosis, and then obviously post-stent, there could be a vulnerability for stent thrombosis also. So there have been studies, there has been a data about this. The causative factors for life-threatening cardiovascular events in diabetic population is they are more prone for accelerated atherosclerosis, and there are other blood abnormalities which are happening in diabetic population, the altered platelet functions and the inflammation. Usually the data says that increased levels of TGF-beta is the marker which tells us that there is more inflammatory response in diabetic population in coronary arteries also. So hypofibrinolysis and hypercoagulability, which leads to increased thrombosis, and this all makes the patient more vulnerable post-PCI. And this is actually translating into this. As I mentioned, the increased TGF-beta leads to more smooth cell proliferation, leading to more neointimal hyperplasia, which turns into more restenosis. And then on the other hand, as I mentioned, there are some prothrombotic things happening in diabetic subsets which lead to more chances of stent thrombosis also. So we require absolutely a perfect kind of a scenario once we're dealing with the PCI in diabetic population, so as to mitigate all such things which are happening in coronaries of diabetic subsets. The vasculopathy, these patients have more chances of chronic kidney disease, and chronic kidney disease itself leads to more vulnerability in such patients. So is this stent, abluminous stent, which is a combination of drug-eluting stent plus a drug-coated balloon, this platform, is it ideal option for coronary revasc in patients with diabetes? I don't know ideal or not, but yes, I would say that this platform has that extra punch which we require to improve the outcomes in diabetic subsets. So I think this has been talked by my previous speaker, Dr. Suresh. The albumin, how it works, it's a 73 micron, so strut thickness is good, and it's a biodegradable polymer. The polymer degrades in 6 months' time, and I'll also show you how the pharmacokinetics of this biodegradable polymer is. The coating has been totally abluminal, so this is not a circumferential coating, and more so, the coating is done after crimping of the stent on a balloon. So not only the abluminal surface of the stent is coated, the balloon also gets a coating, and effectively so further, the edges of the balloon beyond the stent, they also get this drug coating. So once we deploy that, this drug actually goes into the endothelium and acts like a drug-eluting balloon also, along with drug-eluting stent. So these are almost the similar slides which have been shown, and this is what I mentioned, a biodegradable polymer and a abluminal surface coating. And this is not only on the abluminal surface of stent struts, this is also on the exposed parts of the balloon on the abluminal side. This is in vitro drug release. 50% of the drug is released in first 7 days in a burst phase, and total of 70% of drug released in 48 days, which ensures a fast healing and facilitates a faster endothelization. So, and total polymer, as I mentioned, gets degraded by 6 months. This is the data with this stent, and more so, I think we are anxiously waiting for this ability DM global trial, which is being spearheaded by Roxana Mehran, and we have talked about this trial many times, like last Euro PCR also we were talking about this. I think enrollment has been, it's totally complete. The further few things are, as a follow-up, they are going on, and we are likely to have the results in 6 months or so. So this is, this trial was quite an extensive trial, multi-centric trial, and look at this 20 countries, 100 sites, Europe, Asia, Australia, Latin America, and diabetic patients eligible for PCI. It's almost an all-comers trial, very few exclusion criteria. So follow-up at 30 days, 6 months, 12 months, and 24 months. Prospective, multi-center, randomized 1:1. This platform is randomized against best in the class Zines, so they are not, they're going ahead with a non-inferiority, and rather than only non-inferiority, it's also designed for sequential superiority, TLF powered for non-inferiority. So this is the design. The ability DM global, the objective is to compare this platform vis-a-vis Zines. At least 40% of the patients are expected to be affected by multivessel disease, and 30% with acute coronary syndrome. So they're taking all the patients into this trial almost. And the primary endpoints will be ischemia-driven TLR at 1 year follow-up, powered by non-inferiority and sequential superiority. Target lesion failure. So this is how it has been designed, and look at the involvement globally, it's almost everywhere. So with this, I think over the time, our experience about this platform usage made us pretty comfortable. The results have been very good. As Dr. Pratap was mentioning, it is quite a deliverable stent, very conformable. I think we hardly faced any difficulties in hard calcified vessels also. So our comfort zone has been really great to be endorsed by the data which is coming our way. So I've done quite many complex cases with this. So just showing you a few real life cases. This is a LED, very calcified. Look at the extensive disease in the LED. And patient was not a candidate for surgery. So this is how I managed this case. Guiding catheter, and then it is 1.25 rota ablation burr, 180, 170, it was not giving way, increase the speed to 190 to 2 lakhs RPM. So while there was a resistance here at this bend, and a good burring was done, and still look at this, the balloon was still not giving way easily. So sequentially upgraded the balloons, throughout the length, look at this point. Still, despite the rota, despite everything, I'm just going up with the balloon size. This is 2.7512 and still 1 point is not giving way. So after good aggressive pre-dilatation, two abluminous discs overlapped in the LAD was done and got a good expansion, and then one stent into the circumflex, and this is how it looked in the end. A well expanded stent, very calcified vessel, diabetic patient. So this is the kind of stuff. And this is another case, 76-year-old male patient, hypertensive, chest pain, unstable angina, coronary heart disease, LV was normal. Again, a very diffused, extensive LAD, highly calcified. So rota ablation with IVL both. I mean, even after rota ablation, the stent was not being delivered. So first rota ablation, and then this is a shock wave 3x12 IVL rotatripsy done, and this is how it looked in the end. Too long abluminous again into the LAD, and it looked good. So this is the kind of stuff we have been doing this with this platform, pretty comfortable. And the extra punch of this drug-eluting balloon along with the drug-eluting stent, and specifically the 0.5 millimeter extension balloon beyond the stent is also drug-eluting balloon. So that also tends to mitigate the edge restenosis, which is very frequently found in diabetic patients. And as mentioned, that once we deploy this, at least we should keep it inflated for about a minute so that all the drug effectively goes into the endothelium and we get the proper benefit of deploying this different and unique platform. Thank you.
Thank you, Rajneesh. It was actually that second last case which we have shown. If you look at that is what actually Dr. Kannan was telling. You see the angiogram and the result final. Excellent. That means actually this stent I'm again mentioning a patient is coming with a poor patient, they cannot afford this Zions or this Megatron like stent. This is a very good stent for trackability is excellent, unbelievable trackability for a very complex lesion. He showed the case, the calcified lesion looking like a very bad vessel, that middle lady. What was the final result, if you look at, unbelievable. I think my experience also tells that this stent is a good stent for trackability. In a severely calcified bad vessels, you can easily take this stent down. It will not create a problem for us. Any comments?
Excellent presentation, excellent. And you have shown definitely two calcified lesions and how the stent was tracking, as you said. See, when you use an abluminal stent, just think that you are using a drug-eluting stent on a drug-eluting balloon. So it's a 2:1. And plus this edge coating and everything prevent restenosis. And I perfectly agree, it's a highly trackable stent. You have also shown that calcific lesion, how it tracks after preparing the lesion, how it is tracking very well. I also shown two tortuous RCA and tortuous circumflex, how it is tracking with just one wire across. Thank you.
What should be the antiplatelet?
So normally we stick to the same antiplatelet regime which we do in all our cases. It's aspirin and a ticagrelor. If at all there are some high bleeding risks, then we may cut down from ticagrelor to clopidogrel, but that all depends. But normally the regime which we follow stringently, we continue with that.
And moreover, actually, the dual antiplatelet to be continued ideally for minimum 6 months, ideally 1 year, but it is minimum 6 months because the polymer degradation is finished by 6 months. So 6 months, that should be in our mind.
Yeah.
But this stent is actually, when you use only, you will understand.
I think that is the reason that, more and more operators are very comfortable.
Now started using, yes. Thank you, Rajneesh, actually for a real insight. Now the case presentation starts, and I have seen, who is the next speaker? Okay, Shishir and Shishir presenting will be a very complex case. Huh?
Thank you, sir. Good afternoon, chairs and one and all. I will be presenting some cases where I have used abluminal stent. Here is story, 70-year male, hypertensive diabetic, chronic smoker, presented to ongoing dyspnea and angina, EF 40%, inferior hypertension. You can see classical diabetic angio, diffuse lesion starting from long LED, Ramos, everything. And more importantly, you can see in this view, you can see there is a chunk of calcium, as it RCH trunk calcium. So RCA, infrared MI, diffuse calcium lesion, I thought, let me do. And I was not able to take the IVAS to start with to see the imaging, so I'm going little fast. So I go with ROTA, 170,000 watt pressure drop, so bradycardia. So suddenly, then I was able to take IVAC little bit in. So you can see the diffuse fibroplasty plaque following the moment I'm coming to the osteum, the RCA, this is 360-degree calcium, and the size of the vessel is looking to 3.5 to 4. So now still I was not able to take the balloon, so I thought let me have IVL through it, and IVL was not going to with the help of extension guide catheter, Gargilla. You can see this is the Gargilla, I am taking the IVL, and 7 cycle of false IVL I've given, and from the, I started with distal to the proximal, and unluckily I got the perf. So chest pain, BP drop, patient perspire along with the operator, echo effusion, IV fluid loss, NORAD started, pericarditis ready, and there is a perforation following IVL. So luckily I had a balloon occlusion followed by Gradmaster standing. Now I took the trackable stent, that is abluminous 440 from the mid of the RCA to the osteoproximal RCA flare up. And now at this point, initially the PD and PL was okay. Now after this, that is IVL and ROTA, my PDA was looking bad. So I have to have one more abluminous 325 is easily trackable and pot in the distal RCA. Along with that, you can see here the ostium of the your PLV looking bad, and PLV is a big vessel. So I thought let me do justice to the PLV also. So now put a drug-eluting balloon, that is Magic Touch 2.510 to the. So now I use abluminous 2 and DVS. So the final you can see is good result and well expanded stent, and patient is clean. So pre and post. So now second case, 75 ml hypertensive diabetic. This is a point I need to know. PTCA, exactly where the PTC was done in outside, but what is the placement of the LED stent, I'm not clear enough. 14 had PPI also. Then it comes the tropi positive, and ECG shows anterior MI. So you can see the stent, there is a stent in the LED. I am not exactly, I don't know whether it is starting from the distal left main or it is coming to the mid of the left main, I don't know. So there is a stent, and which is ISR, you can see the circ of the ostium, the circ is critical disease, so it is trifurcation. So ISR, Ramos or RLUM or circ, all are disease. So left main trifurcation, some sort of disease in the cranial view, looking in the ostium of the left main also. So disease like this, all trifurcation you can see. So what next? What to do? Left main trifurcation, treat as a bifurcation. LED stent, I'm not where the stent is hanging. What about the Ramos and RLUM? Which technique I need to use, and which vessel to treat as main vessel, and which imaging, and what is the role of DV here. Looking at that, 7 French guide catheter, I branch all the vessel, I pre-dilated all vessel ostium. I'm just going little fast. So now SORC and LED, and now I took the, luckily I saw I am free, there is no strut in the ostium of the LCX. So you can see chunk of the calcium, but the LED stent is not hanging in the strut. So you can see, and definitely there is a chunk of calcium, 360-degree calcium at the ostium of the SORC and distal left main also. You can see distal left main, and you can see critically 60% lesion, and SORC of the ostium also 60% lesion. So I did, I put following post dilatation 3.5, 432 abluminous stent I took from SORC to the left main, and You can see the post dilatation and port 5.512 I got dilated. But what happened? Then the real problem started. I was not able to take my wire to the LED. So LED rewiring was absolutely impossible. Took half an hour to 45 minutes. In no way, neither in guide extension catheter nor in any loop method, I was not failed. So I failed. You can see every time my wire is going to the Ramos or RLUM, neither way I was able to take wire into LED. So at that point of time, I thought, let me do some justice to the RLUM or Ramos, and did the just post, dilatation, balloon dilatation, and I got result. But at that point of time, my patient was chest pain free. I thought, let me stop here, let's do some justice in next way. Next day, I went to the radial only, but you can see the loop after 48 hours because I have done justice to the LED. So luckily, this time my wire goes to the LED easily. So, and again, SARC and LED, I did the YVAS, and LED stented was absolutely malapposition, and at the stem of the LED was critically diseased, and the stent was under expansion, underexpanded, and SARC yet I have not done justice. You can see still I have not achieved a good amount of MLA there on. So you can steal the LED mid and left main. Then left main was okay by the time, but distal left main was not good. So at that point of time, I did the LED justice. I went with semi-compliant balloon followed by open balloon. Then I put a DB magic touch 3.520 in the LED, and with magic touch, and I put a magic touch in the LED, and SARC I did a kissing, and followed by, you can see I got a result, and D1, and in the D1 I put a DB also. So this is a good result. So pre, you can see, and post, I did justice. Third patient, diabetic, again SS condition, RCA attempted, plastic was failed, you have 30%, CSG outside, critic, you can see diffuse lesion in the LED, SARC, and usually it's a diabetic vessel, triple vessel disease, and RCA CTO. So CABG was not opted by the patient, then which artery and which technique, and patient was not had CVA. So I thought, let me do LED plastic, and now LED CTO, so I went to Caravel, Sion Black and filter XTA. So I put a stent abluminous 336 from the mid of the LED to the mid to distal LED, and you can see with a mini cross technique, diagonal, here I dilated the diagonal pre-dilatation, and I put one more stent in the LED. But before, here I want to know, before I cross the diagonal mini cross stent, you should optimize your diagonal stent. This is the point I need to. Before you cross the stent, side stent, you have to optimize with your maximum post dilatation to the balloon. So I optimize, then I cross with stent, then you can show LED stent deployment and post dilatation and pot, and followed by kissing, then report, and I thought I did the justice. You can see diagonal well opposed. It is a diagonal I was, and I achieved a good amount of MLA, and LED also. You can see the distal LED where I put mid to distal. You can see that well opposition, and I have achieved it. So final, you can see this is the. And now RCA CTO in the next sitting, I did with RCA filter XTA, then I went to the guide 2, then IVAS was, you can show this is, IVAS was again, this is a diffuse lesion, and from the, under IVAS guided, I put a 345 abluminous drug stent from the distal to the mid, followed by osteoproximal RCA, I did one more stent in 3.524. So 2 stent, IVAS guided, 2 CTO, 1 bifurcation, and finally you can see this is the good ML I have achieved, and the stent is well expanded, and you can see RCA SARC, but at the same time, in the same sitting, I did the SARC, which was contrastless, that is 0 contrast, 2.5. So pre, this is the post, you can see. Okay, and why did I prefer this abluminous? As my previous speaker has told, absolutely is trackable. I don't want to show the same stent. Only thing I do compare. So what are the other current drug electric stent available and what is the advantages of abluminous crimping done after coating the previous other stent, but it is the pre-crimping coating done, and dual side coating drugs is the abluminal coating, so that the faster re-endothelization is achieved with the coating, and only because the more drugs are available in the abluminal and unidirectional flow of the drugs can be done, and focal restenosis where you can have in the other stent. Here both as the drugs and stent is coated, and the 5 both end of the stent is coated, so there is a chance of decreased stent restenosis, edge restenosis and focal and edge restenosis also decrease, and inadequate result in a diffuse lesion. We have diffuse result data also, the clinical trial also shows, and inadequate result in the AMI patient, and I saw the 2 patient in AMI patient. So I think we are having a stent, both having stent and drug-eluting balloon, and which is trackability, and not only trackability, side vessel also I saw 2 cases, side vessel also. So I think we are having a good stent by the Concert Medical. Thank you.
Excellent, excellent cases, Dr. Shishir. And you have presented different clinical scenario where abdominal stent is useful. Heavily calcified lesion after calcium modification, how it tracks, and long stents, how it is being used. I have just one doubt. The first case, there was the perforation. Was it, you used rota, after that you use IVL. Perforation happened after IVL?
After IVL. Still I don't know what it, because Disrupt 3 studies show there may be perforation, but usually IVL does not do any perforation.
Very rare, very
because
rare.
balloon perforation occur in the calcium nodule, but getting vessel perforation is still, I don't know why.
Maybe the rota has almost produced a near perforation with this IVL, it would have opened up, something like that. Because IVL
But before that we had
very, very rare.
before taking the IVL, we had check shoot, but no perforation.
Okay. And the second case where there's already a left LED stent, and you didn't think about doing a DCB to ostial circumflex?
I saw now. I finally semi-complaint, OP, and then I put a DCB in the LED.
Circumflex, ostial circumflex.
No. There is a critical disease. I put a stent. SIR2, because left manual disease, ostum the left manual disease, distal left manual disease, and circ of the, ostum the circ. So I had a stent from the circ to left main, and DB to the LED, and DB to the diagonal.
Okay, well done. I think with the interest of time, we'll go to the second person. Anything, Dr. Khanna?
Sir, in the second case, the LED wire was not going. There you can see the, you have taken imaging there that this previous stent.
I was not able to take the LED wire. Now that's why I was not able to
No, from LCX or Ramus.
I did.
I think
Because no
we'll-
plan.
Initially I did the imaging. There is no stud in the circ, but after putting the stunt, I was not able to take my
Wire
LED
into main LED. Yeah.
Thank you for nice presentation
Thank you,
and a different scenario. Now we go to the last case of this session. Dr. Richa Sharma with her presentation.
A very good afternoon to the chairpersons and the seniors and colleagues. So the topic is PCI in patients with diabetes, innovative DES plus DCB. We just went a step ahead and used DCB in patients with diabetes. I'll be talking about that. And we all know that diabetes is a vasculopathy. It is not a lone endocrinopathy. And the most fundamental pathogenetic aspect is phenomena of endothelial dysfunction. A lot has been talked about in the previous presentations about how diabetes causes endothelial dysfunction by oxidative stress, advanced glycation end products, and the mechanism how diabetes is leading to increased atherogenesis and diabetic dyslipidemia, and particularly in smaller vessels, diabetes is causing a havoc actually. And a lot has been said about the stent platform of Abluminous, which is giving both DCB as well as DES advantage to the patient. So we'll just go ahead and discuss the cases. So the presence of diabetes remains a predictor of worse outcomes even in era of drug-eluting stents. That's why the development of something innovative is required, either DES plus DCB platform or just going ahead and leaving a stentless vessel using a DCB. So DCB provide mechanical expansion. They deliver an anti-proliferative drug aiming to reduce neointimal tissue growth, positive vessel remodeling, And they reduce angiographic late lumen loss. Also, they have been studied in de novo coronary lesions. And our basket small 2, it has actually shown us the way that we can use DCB in de novo lesions in smaller vessels with diabetes. There has been clear-cut advantage in reduction of TVR in diabetic patients with the usage of DCB. So just this case, she's a 65-year-old diabetic female who presented with rest angina since past 3 to 4 months, and she was a follow-up case of infravolemi for which RCA was stented in 2022 with 2 deaths of 2.75 and 3.0. CAG was done, which showed a double vessel disease. RCA stent ISR was there, and LAD was also critically diseased, with giving retrograde collaterals to RCA. Now, our plan was, she came for a basically stage PTCA to LAD, but now we have RCA in front of us, which we have to treat. So we took a Fielder XT wire and tried to do the sequential dilatation with 1.25 and 2.0 balloon, but 1.25 balloon could not go beyond this point. We can see here, it just could not go beyond this point. So I had to see where two causes can be there, whether my wire has passed behind the stent studs or there's something inside which is leading to this problem. So I took a guide, but I couldn't do imaging at this point, and just took a guideliner. With inchworm technique, I just tried to move my balloon forward, and 2.0 balloon, semi-compliant balloon could then be passed forward, and pre-dilatation was done. After this OCT run was taken, and we can very well see neointimal hyperplasia was there, and then coming on to this point, there is calcium nodule, which has been neocalcinosis actually, which has developed in this patient. This particular point, this, yeah. This area is showing neocalcinosis. NIH is seen in this patient. So it is both mechanical and biological factors in this particular patient. Now, since she was a diabetic female, I didn't want to stent here, and I just wanted to use a drug-coated balloon in this patient. Though for neoatherosclerosis, stenting is required, but it would give 3 layers to the patient. So I did a 2.75 into 40 mm DCB in distal RCA and a 340 DCB in proximal RCA, and this was the final result. Patient is coming for follow-up. Her LAD was treated later on, and she's doing well now. The RCA is also flowing well on follow-up when LAD was done after 1 month. This was the second case, 61-year diabetic hypertensive male who presented with ACS non-STEMI, troponins were positive. And on angiogram, we can very well see that all the vessels were flowing well except for his diagonal. It was a large vessel diagonal and critically diseased. So I thought that rather than just stenting here, rather than using a small stent in this vessel, I would just do a DCB and pre-dilated, prepared the lesion with 2.5 NC balloon, and took a 2.5 into 20 magic touch here, dilated it for 90 seconds. And this was the OCT post DCB balloon, where we can see that lumen gain was adequate, more than what the guidelines say, that it should be not less than 30% lumen gain. So lumen gain was good. This patient was followed up again after 5 months, and his angiogram was taken, which showed a beautifully flowing diagonal. And this was the OCT, which showed late lumen enlargement as well, and positive remodeling of the diagonal. Yeah, this was the vessel. This was the LAD. So this didn't hamper my LAD, and diagonal was taken care of by just a drug-coated balloon. History of EF of 45% with anterior wall mildly hypokinetic. Patient was taken for angio. And this was the angiogram, which showed LCX-OM1 bifurcation. Then we have left main 011 disease, wherein osteo of the LAD is critically diseased, just a pinpoint disease is there. And osteo of the circumflex is also showing almost 60 to 70% of the disease. We can see that the bifurcation angle between LAD and LCX is more than 70 degree, and bifurcation angle between circumflex and OM is less than 70 degree. So now what should be the plan? This is an 85-year-old elderly gentleman, diabetic person, who has already had an MI situation and now came again with ISR. So I wanted to do minimum intervention, minimum stents, but yeah, the stenting done 2 years in 2021 was 2.5 into 48 DES, which was deployed in LED. So that was probably a mistake and a learning point this time that such small stent will always, always produce an ISR. RCA stent was patent. So the plan was to address M to LED and circumflex and maybe DCB in side branches. That is the circumflex, either OM or circ after OM. Plan C was to do a string Q-lot if LED stent struts are too much hanging into LMCA. Now in this, I couldn't use imaging because of the financial constraints, so I just have to see in stent boost only whether the struts are coming back into LM or not. So I wired the circumflex and OM both and dilated with 2.5 into 18 and 2.5 into 12 balloons in OM. Kissing balloon was also done with this itself so that I could gain more space into the vessels and they can grow easily. After this, we can see that the OM came out to be a huge vessel. It was not small vessel and I couldn't leave this vessel. So the flow in the LED at this time was getting a bit reduced. So I thought that I'll dilate the LED first without compromising any flow. And since he was an 85-year-old man, I couldn't risk losing the LED or even slow flow in the LED. So LED was dilated at the ostia and also at the distal end with the same 2.5 balloon. This was the flow, this was good. Then I took a stent into LCX OM1, but there was some difficulty for the stent to get into. You can see in third cine. So now I realized that yes, the struts are hanging into left main, overlying at the ostia of the circ. That is why, but the stent passed easily. And I deployed the stent there into circumflex OM. Pot was done with a 3.25 into 10 NC. No. At this point, I tried to take a 3.25 NC, but it was not able to cross from the ostia of the ostia because the left main, into the left main, the stent struts were hanging. So I thought that I will tackle the LED first, dilate the ostia of LED adequately so that the stent struts will just oppose the wall of the vessel. After dilating it, took another stent into LM2 LED. It was a 3.5 into 26 stent. And distally also a 2.75 into 38 stent. I was making 3 layers of stent at this very point, but I know since my apposition is adequate, the stent size is adequate. Earlier it was just a 2.5 size, so I had to dilate this, and so I took another stent and dilated it. After this, a pot was done with a 4.5 into 8 balloon in left main at 14 atmospheres, and we can see some pinching of the LCX ostia at this very point. So LCX was wired, fielder FC recrossed in LCX OM, but my balloon was not able to cross. So I took this fielder FC into LED, and the run through from LED by pullback technique just entered into LED. Yeah, we can see it here. This LED wire was then taken into circumflex. The stent struts, they were dilated with a 2.5 into 18 balloon. LED stent was post-dilated sequentially with 2.75, 3 and 3.5 NC balloons. Thereafter, run-through was recrossed into distal circ. Stent struts, again in distal circ, they were dilated with 1.5 and 2.5 balloons. And following which, I did a DCB, magic touch of 2.75 into 20, sequent neo, PEB, at 6 atmospheres for 90 seconds into circumflex. Took a balloon into the LCX OM, did an FKBI with the same DCB and an NC balloon. Meanwhile, I realized that I dissected my LED down while wiring, so I had to fix that also. So I first just cleared the circumflex, did a pot with 3.25 and kissing of the left main and LED with 3.25 into circumflex and 3.5 NC in LED. This was the result. I wanted to secure the ostia of circ also, so I took another DEB for the ostia of circ. Yeah. 3.5 into 25 DCB from distal LM to LCX was taken and deployed. FKBI with the DCB and 3.5 NC in LED was done. and a final pot of 4.5 into 8 was done. This was the final result. Patient was discharged on ecosprin and clopidogrel 75 mg ODE.
अजय ऊपर जा.
Would request everyone to please settle down for this interesting session. And I believe the first speaker.
Okay. Ajay Joshi, sir.
Ajay,
Joshi.
right.
He'll be speaking on innovation to implementation, bioabsorbable, resorbable scaffolds. Ajay.
Please. Welcome, Ajay.
Good afternoon, everybody. At the onset, reference to some of you who have been my teachers here, I'll be today talking on innovation and implementation, the journey to the promised land of leaving nothing behind when sun starts bioabsorbable scaffolds. So we all know that permanent caging of metal with metal implants, we cage the vessel and the vascular remodeling and vascular physiology is jeopardized. That's the concept behind getting a resorbable scaffold to prevent the adverse long-term events. And ultimately, everybody has an ISR. And once they have an ISR, the re-intervention is always a big issue. So with that novel concept of leaving nothing behind, the BRS or the reabsorbable scaffolds have come through. And it's a part of vascular restoration. DEB is also a part of it, but here we'll be talking about scaffolds. And we all know that over a long term, if we compare between metal stents and a BVS, ultimately everybody will have an ISR. The risk is 2 to 5% with the new generation drug-eluting stents. The advantage with the scaffold is that the long-term risk of having a scaffold and then in a period of 2 to 3 years, you are leaving nothing behind. And there's no risk of any neointimal hyperplasia, which is there in cases of any scaffold or a metal stent or a drug-eluting stent. So, but it's not all hunky-dory everywhere with scaffolds. See, scaffolds have their limitations. They have a limited radial strength, their trackability, and it's not one size fits all. So we have to know the constraints of these reabsorbable scaffolds. And while going ahead with them, I'd like to take you the journey of how we have in a hospital deployed 24 of these BRS stents, scaffolds, and what are my experiences, what are problems through which I have come through, and where the way is the way ahead to it. And the most dreaded complication is everybody dreads is the scaffold thrombosis. It's the thing which always keeps in your mind that you're putting something which may not expand well, and you may come with stent thrombosis. So there are various grades of stent thrombosis: subacute, subacute, late, very late. But we all know about patient-related factors. We all know about implantation techniques. We all know about whether we imaged it well or the DAPT which the patient is taking. But what is which limits us while using this device is we are aware of the strut thickness, the radial strength, and that thing in our mind that over a period of time there's going to be uneven degradation of the polymer or the scaffold, it's the PLLA or the. That's always in our mind, which which limits us from using this device. So, as recommended, it's only for type A lesions, young patients, I'll say, non-tortuous, patients who can tolerate dual antiplatelets initially for at least 1 to 2 years. It's not that you apply BRS and you can do it with DAPT. So patients who can tolerate that. There's always something which I say, there's always a type A lesion, there's no type A angioplasty. So we come across a lot of coronary profiles in patients, left main disease, ostial lesions, bifurcation, ISR patients. Here I'll always say it's not the modality of choice, especially in ostial lesions, left main, complex lesion, ISR patients. In CTO, if you have really opened the vessel well and you find a short segment CTO, you have prepared the bed well, in even acute MI patients, we have a discrete lesion and you find that you need a scaffold to prevent the recoil. And even calcified and diffuse disease, you have landing zones, it's a plus minus. So the greens are the plus minus depending on operator experience, his expertise to use them, but definitely initial part, young patients, non-tortuous, discrete lesions, type A lesions. Total no-no in patients with red lesions, with the reds. So we have to use our tools right, use all modalities which are available to us when you're using a scaffold, whether it's imaging or any form of imaging, IVUS, OCT. In our patients, we have used OCT. And with any other angioplasty, it goes very simple to say, you have to choose well. Then one size doesn't fit all. You can't just jump into using, you have to keep everything in mind while using a BRS. So we have the kid on the block is Mirus 100 at present as of now compared to Absorb, which was a 150 micron thick. This is just a 100 micron PLLA backbone with sirolimus eluting with a very good radial strength and got good optimal side branch access is there. So this is the thing which we have with us. And if you say that it has got enhanced radio opacity, it has got markers, which has got dual markers at the end, and it has got best-in-class stent thickness and best-in-class crossing profile. So I'll take you to the cases. Now these are the cases which we have gone through. Initially, we have done all those type A lesions. The PSP stands for you pre-size it. You prepare the bed well. You preparation, sizing, and post dilatation. Now it's simple. It's been used for all types of angioplasty. But what's special here? Because special is that you can't do much with post dilatation. So you have to be very precise. And as far as our recommendations, we'll always use any form of imaging prior to deploying them. So this is a simple lesion which we had done. We have imaged it. We have achieved the MSAs. Even in RCA, it's a discrete lesions. And we have been able to deploy it well, but we have imaged it, and all our cases have been imaged. We have never left any, after pre-dilatation, we have always done a OCT, deployed the BRS, and then done a OCT. So even this guy had a osteal LED disease with a significant large OM disease, and he was a diabetic. We first fixed his OM and then did his left main LED plasty. And again, he was imaged. So point is that imaging, if you can afford, always do with imaging. It is preferable and it is indicated because you have to know that it's been well expanded and well opposed and you have achieved the stents area. Now here again we imaged it. Again in tapering vessels with ACS, we have done BVS and achieved the adequate diameters. Again imaged it, and even there's no problem with access to side branch. In this image, if you can see, the patient had a significant LED disease, and we put a BRS and we have done imaging following it, and we found that there was no proximal or distal dissection. The stent was well expanded and well opposed. And again, it was imaged. There's a patient who came with unstable angina, tandem PCI done to LAD, proximal and distal LAD. He came with distal LAD ISR as well as an intermediate lesion in the geographical miss area. He had an ambiguous stenosis there. And following FFR and OCT, we found that he had neointimal hyperplasia in the distal stent as well as the ambiguous between the two areas. The geographical miss also had a significant stenosis. And this is where we did the cutting followed by a deb of the distal LAD stent, and in the two geographical areas we managed to put a BRS after doing an OCT after adequate vessel sizing, pre-dilatation, and then we deployed. This is the area where this is the ambiguous part of between the two stents. We have already covered in the first images. This is the ambiguous part of between these two stents. So neointimal hyperplasia was there, and this is a cutting balloon which we did with Wolverine 2.5, deb with 2.75, and the geographical miss was covered with the BRS. 3.25, 24, and post BVS deployment, these are the images. And this were also taken and post BRS implantation and OCT was done. So we have kept it mandatory that post dilatation, bed preparation, we should do an OCT, and post BRS deployment, we should do an OCT. So these were the results. We have achieved the adequate MSAs. So there's nothing which says that you can't do twin BS in calcified lesions. Here we had a 55-year-old hypertensive diabetic dyslipidemic with LBB, LV dysfunction, EF of 40%. He had a calcified lesion, but the calcium was not intimal; it was adventitial. So we did an IVUS. We made a good bed preparation. We took an NC balloon. We found that the lesion was not dilating well, as you can see. Even with the shock wave, we prepared the bed well. But after making the bed well and taking an imaging, we found that we had achieved a good area. We had prepared the bed well. So he's a diabetic, long-term results are there. He's got a big size vessel. Once we were sure that we have achieved pre-dilate, post-dilatation we have made a good bed preparation, we went ahead with a MERAS 3.529 in the mid-RCA, and we had no problem in overlapping it with we post-dilate the MERAS IVUS, and then we had no problem in actually overlapping the stent with the 4.5. Proximal MERAS was 4, we post-dilated to 4.5, so the distal MERAS was 3.5. So this is my, everything is not, when we go, in our story, when you make good bed preparations, you are very aggressive, you land up with some complications too. So we have two complications which we had in our case. One was intermule hematoma and perforation. Here, the patient had an ACS, possibly an inferior wall MI. We thought the lesion in the RCA, mid-RCA was discrete. We did imaging. We found the lesion is just fibrothrombotic. We did an OCT. We planned to do a MERAS for her. And bed was well prepared, but overzealous bed preparation. And while taking the stent MERAS ahead, we missed probably in our judgment. There's a problem in the judgment that the intermule hematoma was there. And while we were taking the MERAS ahead, we had landed the MERAS little proximal to the intermule hematoma. And we can see in the image on the left that there was an intermule hematoma here, and which we had probably missed while deploying the stent. So we covered it again with the DES, and the intermule hematoma also progressed proximally, which we had to again cover with another DES. So we had to put two DESs, proximal and distal, to the intermule hematoma. And this was the final result. Similarly, we were over-aggressive in dilating a MERAS, which we had put distally in the LAD. We had a perforation, but since the bed was well prepared, we were able to deploy a covered stent distally, and this was the final result. So ladies and gentlemen, we should understand the limitation of this technology. Pick your patients right, use imaging, bed preparation is key. If adequate preparation can be achieved even in calcified vessel, BR is not absolute contraindication, but post-bed preparation, imaging is must before deployment of BRS. In long regions, it can be easily overlapped, and post-dilatation is must. Don't leave much for post-dilation, and be ready to anticipate any complication and treat it. Thank you, ladies and gentlemen, for patient hearing.
Thank you, Ajay. It's a very nice demonstration of some very pristine results. We'll have a discussion after the entire session. And now we invite the next speaker, Dr. Selvamani. Okay.
Ajay, please join us on the dais. So whenever a speaker drops out in South India, he's always replaced by Dr. Selvamani. He's got the maximum repository of cases.
Okay. So again, I thank the organizers, and then I have been included as at the last moment. And anyhow, I'll try to do some justice for this topic. So can you just load it, please? So today what we will do is, I will just tell you my experience with BRS. So that is biovascular scaffolds, insights, what we have. And probably when you consider it just as a biovascular scaffold, probably we have a very large experience of 1,450 right from the time of Observe here. And then we have personally more than around 700 plus. And that done a lot of cases from different varieties of disease. But of late we have just slowed down, there's so many limitations as of now. So we will just see few the previous cases as well as the present cases. So look at this case here where I have overlapped the two BVSs, and we have a follow-up of these cases. And even probably we have a 11 years follow-up of this. So this patient was treated in 2013, and the pointer arc is here, okay. And he had a long LAD lesion here, and we had something there in the ostial LAD. So we had one borderline lesion in the RCA. So but this was stented with 2 BVSs. From the entire LAD was stented, and this is the proximal stent getting deployed, BVS getting deployed in the proximal LAD. And in the ostium left main alone, I had to put a drug-eluting stent at that time. So this was done in 2013. So what happened to this patient now? You just follow up, and this was the final angio in 2013, and now he underwent a check angiogram in 2016. So this was it. So 3 years after the procedure, it was almost looking the same. And at the time, we did a OCT in 2016 to make out what it was, and almost very few scaffold parts were seen there. And then you have an IVUS to the left main there, which was also very good, well expanded. So we did a CT angiogram. It's a very good follow-up tool here. See, what you are seeing here is these are the markers from the biovascular scaffolds, what you have. And this is a drug-eluting stent. So this is how you make out a biovascular scaffold and a CT coronary angiogram. And same patient now in 2013, so what almost around 10 to 11 years follow-up now. So this is the angio here. The entire, you look at the OCT here, the entire biovascular scaffold which we had put right from the middle of the LAD into the left main has completely disappeared. And look at the vessel diameter here, and it is what we call it as a golden tube appearance here. And when you come to this, you see here, there is a marker. You can make out clearly on the OCT that there is a platinum marker here. You can make out this, see, there is a platinum bead here. These are the BVS markers that you see. And as I previously showed you that you can make out on a CT angiogram, only markers are seen, nothing is seen on the follow-up. So the same patient which I had put a left main ostial drug-eluting stent here, even that we just checked here, you can see there, it is a beautifully endothelized ostial left main stent which you can make out on OCT. So we have a special technique to see the ostial left main, and with this I have just made out, this is the ostial left main in the same patient with excellent follow-up, excellent endothelization. So probably in the ostial lesions, we were not treating with BVS at that time. I think probably that was good. So very short stent in the ostium, and the entire LAD was stented with BVS with an excellent follow-up at 10 years, and patient is doing extremely well now. And due to lack of time, I'll show you some important things. This is the overlap BVS, how it looks. You see here, when you look at the OCT, you see the 2 layers of the BVS here. So this is 17 months after implantation. In the overlap segment of a BVS, you can make out 2 layers, and then it's an excellent lumen maintained there. And that is how that overlap segment looks there. And then the same patient, and absolutely there are no struts, and the entire vessel is native vessel. And many times you see a lot of positive remodeling, and the vessel has become positive. And when there is a restenosis in a case where we have done a BVS, see, this is almost 9 years post BVS. He had a BVS in this ramus here. And when you look at the angiogram, most of my juniors, they said, sir, you said post PTCA, we can't see anything. When you just concentrate on this part, see, there is something like a marker. I don't know whether you can see it on the screen. See, if you concentrate, there is a BVS marker which you can see. And in this shot, you see, look at this part. So this is the BVS marker that we have, and there is one more marker here. So this is the spot where he had undergone an angioplasty with BVS, and then you do an OCT study there. So in the OCT, there are nothing there to say that we had done any angioplasty there. We could have some pathological finding. Lumen was narrowed at one point, and this patient, because of his low lumen, 1.69, his FFR became positive. So the same patient had one more BVS in the RCA, which was very clear, almost around 11 years, nothing was left, totally clear. And in this ISR, what we could make out is there were areas of cholesterol crystals, narrow lumen, macrophages, and microvasculature, and then, of course, a golden tube that you are seeing, and few lipid necrotic core was seen. So, and there was some calcium. So with this finding, and then you can see the BVS marker, that is the platinum marker, alone on an OCT, you can just pick it up like this, and you can follow up these patients. I think with this type of cases and excellent follow-up, I think BRS is an excellent therapy, proper deployment technique, which was this key. We have a follow-up of almost 1,400 patients with a OCT of around 120 patients, even 9 years, at 3 years, 6 years, and now at 11 years follow-up, doing extremely well. We had very few cases of stent thrombosis, and I think if used in a proper way, and especially if it is image guided, there will be a great impact in this therapy, and our follow-up with this device is excellent. Thank you so much.
Thank you, Dr. Silvamani. Please join us. Can I invite Dr. Gautam Sarup now from Apollo Hospitals, Lucknow, and he's keeping a very meticulous follow-up of the patients of BVS that he has done. So let us listen to his experience. Gautam.
So thank you, NIC, to giving me the opportunity to share my BVS data to respected chairs and the audience. So I personally don't have much experience with the older generation of the BVS, but the new launch of this second generation BVS, right from the starting, we adopted this technology to our center. And right now we have touching almost 100 cases with this second generation BVS. So again, it is the great learning platform for all of us to share our experiences with this new generation, this BVS, so that we can learn from each other and scale the technology further in the interest of the younger patient. So we all know the journey of the stents. Now we are coming with the second generation BRS, and proudly it is Indian. And they have basically purify and think the failure of the older generation of the BVS. They reduce the strut thickness of the this stent in the 100 microns. And again, there is no limitation of the any kind of the storage. So the previous speaker has demonstrated the strength and the advantages of this particular stent. I am coming with my center's data. We have started using this stent right from the beginning of the March 2021 to the May 2024. Till now, we have basically implanted 96 this BRS. In 71 patients, there is a single mirrors. Twice, it was in the 8 patient, and there is a 3 BVS in the 3 patient. So there is a 96 scaffold till now. The average male 82%, 18% females, average patient 52 years. Most of the lesions are in the LAD, and then the RCA, and then the circumflex. Again, the 19 and 24 millimeter were the maximum used length, 3 millimeter the maximum diameter, and 319 is the most commonly used size in my patients. Again, we all know that this is the new technology. We have to understand the limitation, and we have to clearly identify that this stent is actually a scaffold, not the metallic benchmark. So we have to understand this. So the imaging, the importance of imaging is very important during the deployment of the stent. So most of the patients are under the imaging guidance. If you talk about the outcome of this procedure as well as device, 98.5 is the procedural success and 96% is the device success. There is 2 patient that we have faced with the stent dislodgement, 1 patient with the TLR, and 1 patient has basically diagnosed with the non-cardiac death in our follow-up. So there is no scaffold thrombosis. Again, this is very encouraging. Right from the 3 year, we are closely following our patients. So again, this is an important thing, right, from if you are going to adopt this technology, there is a three things that is known as the PSP. And again, the most important thing in the PSP is the pre-dilatation. We all know that this scaffold is not made up of the metal. So we need to understand that the first P is very important in terms of the long-term success. We have to basically identify the lesion with the QCA, with the imaging, and we have to prepare the bed for the long and better term results. That is why this PSP is consolidated by this new generation of the stent, and they incorporate two balloons along with that so that you can basically remember the steps of the pre-dilatation, then the appropriate size, and then the post-dilatation. So the right technique, as the previous speakers has basically elaborated the right technique of the pre-dilatation, stenting, and the post-dilatation. Most of the stents, they recommend that the post-dilatation it to the up to 0.5 millimeter you can post-dilate, and it is recommended. So now I am sharing some cases to all of you. So in the very beginning, we don't have imaging at our center, so we started like a proper PSP method. We wisely select the proper candidate, younger patient, and the smoother lesions, and then we deployed like this way only. So this was the final result, as you can appreciate, with the proper selections, proper bed preparation, and the ideal post-dilatation. Over the period of time, we started doing our cases with the imaging, and that you can appreciate that identify the lesion character, whether it is thrombotic or fibrocalcific or fibrous. We decided the appropriate size, and then we validate with the, again, the imaging. So this is the optimal way of doing this, this method. Over the period of time, we realized that can we test this BVS into the different conditions. And the different condition is like osteal stenting. What is the overexpansion? Can we overexpand it further? Or can we use into the calcified lesions or CTO? And can we use as a overlapping? So again, so this is the angiogram of a patient, young patient presented with the ACS. And we try to put this BVS to the osteal positioning. But again, we dilated the bed good. You can see the expansion, but unfortunately, the osteal positioning is missed and stents slipped into the LMCA. So we don't left any option. Despite that, the post-dilatation, we post-dilated this to the 4 into 8 millimeter, and this was the final result. These things taught us like the both things, like even we can post-dilate it 1 millimeter further, and there is a good side branch access. There is no compromise ostia of the LCX, and this is beautifully flowing, and the patient has completed 2.5 years of the follow-up. We have taken the close follow-up that patient, and patient is doing well. But again, the message is that you have to avoid the osteal stent placement, because ostia is a fibrotic point, and most of the time scaffold might slip either backward or forward, and you can miss this thing. Similarly, if you see the overexpansion, most of the time if you do the IVAS and if you want to place the stent, it is not every time that you have to expand only with the limitation of the 0.5. So we regularly post-dilate up to the 1 millimeter 3.0 stent, and we post-dilate to the 4 into 10. We validate with the IVAS, there is no stent deformation or stent disruption. So we are pretty sure that we can do the post-dilatation to the up to 1 millimeter as well. Similarly, a new concept that is proximal vessel DES and the distal vessel DEB. So we put at least 15 patients in our study to DES and DEB. Most of the patients are very young patients. We do not want to put the metal inside the body. So we do like this way, and with the proper validation, and we do like the DES and DEB combination. Similarly, calcified lesion, over the period of time, we understood that the lesion preparation, as Dr. Selvamani has mentioned in the huge case series, the lesion, the bed preparation is the most important thing. Here you can appreciate that the 360-degree calcium And the cutting balloon, most of the time I feel that we underestimate the power of the cutting balloon. Most of the time we use to cut the lesion if they are fibro or fibrocalcific. So we use the mirrors and then post this thing. Again, with the tortuosity, we need to understand that this scaffold is not so much trackable because they don't have the much radial strength as compared with the normal DAS. So in these particular cases, if you feel that there is a tortuosity, you need to take the guide liner direct, and then you have to track the mirrors with the guide liner. And definitely you have to take the 7F guide if you are using 3 or 3.5 millimeter BVS. So in this case, we track this with the guide liner, and this is the end results. So we need to understand and to avoid the BVS dislodgement we have encountered in the 2 cases, and by this thing we came to learn that in the tortuous artery we can place a guide liner, track the BVS, and then deploy it like this. So again, we can prove it like this way only, and we have follow-up up to the 1 and 3 years with the OCT, IVUS, and the CT coronary angiography. All the patients are doing well, and there are some or non-significant ISR over the period in some minimum patients. These are the OCT follow-up data, and we can see that the stent is almost reabsorbed. This is the 3 years recently we have done in a patient, and this is the 3 years follow-up with the IVUS. The stent scaffold is almost absorbed. There is no remnant of this, only the minimum remnant is there. So to conclude, the second generation BRS have been developed to overcome the limitation of the first generation BVS in terms of the more thinner stent, better navigation, better cell designs, and etc. Image-guided PCI, proper lesion selection, PSP method of the deployment, and proper follow-up data will continue in the past experience to overcome and the limitation of the first generation BRS. And centers where imaging is not fairly available or any financial constraint, PSP is the only way to take this technology forward to make the good results. And again, we have done the OCTI was follow-up in our patient to validate initial and long-term results, and yet to validate in the ostial positioning, overexpansion, and the complex coronaries. So I will end like saying in another 10 years, we may look back and laugh that all the time we have used the leave behind the little pieces of metal in patient vessel. I do not know whether this journey will take us where, but we are pretty sure that these Indian makers are doing very well in terms of the futuristic visions. Thank you. Thanks for your kind attention.
Thank you, Gautam. And can we have Girish now for the last presentation?
Gautam, please publish your data. That's a phenomenal amount of work you've done.
Good evening, chairpersons and colleagues. We had privilege of using the first generation as well as the second generation BRS. Now I think with the second generation, we have about 60 scaffolds that we have implanted. And some insights I thought I should share. If you look at this, we all know how it looks. How it's different is just the strut thickness is less, and you have 3 marker. And we need to understand that there are 2 kinds of polymer. One is PLLA, the other one is PDLLA. PLLA is what the skeleton is made of, and the durability of its strength is for 6 months. PDLLA is the one where the amorphous drug stays and that elutes. That lasts about 100 to 120 days. And these are things of significance, and how it is loaded on the distance between the markers and the balloon marker is about, I'm sorry, if I go back. If you see here, from these platinum markers to the balloon marker, it's about 1.3 millimeter, but end of the scaffold to the beginning of the balloon marker would be 0.1 millimeter. These are small things that you would realize. When you look at the durability of this scaffold, from the 0 to 6 month, the radial strength would be good because the molecular weight is preserved and radial strength will follow that. Beyond that, the radial strength declines and the vasomotion begins. It's also important by which time these polymers have to be endothelialized, otherwise they may drop off into the lumen. So that's how they have devised. And looking at the crystallinity of the PLLA, that holds good for 6 months. When you look at the first generation, which is absorbed 2 years, and end of the 2 years, you would see these boxes on OCT very clearly. But with these Mirrors 100, what we have done in the recent one, you can see that where the scaffold was there, those are much thinner because almost 50% less in the thickness. What is the concept? When you look at these scaffolds, we call ghost scaffolds beyond certain time, because beyond 2 years, the preserved boxes that are seen on OCT are in fact spaces filled with the remnants of the scaffold struts in form of highly degradable polymer residue with significantly reduced mass and molecular weight. So it's just a hanging tissue with proteoglycans and extracellular matrix and occasionally very late cells that have replaced. In short, what it means is the scaffold polymer has been largely degraded and replaced by proteoglycans from the tissue. So it's not always what you see those as boxes, that they are remnants of the original scaffold, but the body tissue whose reflective characters are slightly different. I can show you here in this. OCT images illustrating the changes of strut core appearances from day 0, 1, 2, and 3 years. You can see a 0 to 1 year, they're still there, the ghost scaffolds. When you look at the 2 years, look at this, and by the end of 3 years, they're hardly there. That's how it is. The other box that are seen on the OCT are in fact filled with the remnants of the scaffold. You can see that bigger ones, and filled with the human tissue subsequently. But when you use this gas chromatography, once when they were implanted in the mice and then they were sacrificed at day 0, 1 year, 2 year, and 3 years, and OCT was performed, also a gas chromatography was performed to see what was the tissue inside. If you see at day 0, 94% was the scaffold component. At the end of 1 year, you would see that there's only 35% of the scaffold material, 65% is the animal material. At the end of 2 years, it was 98% the living tissue, and only 2% was the scaffold material. And at end of 3 years, 99.3 was the human tissue, the animal tissue, and only 0.7 was the PLLA. So that means to say it truly disappears. I'll show you a case, many have demonstrated. I have a couple of cases. 42 years old female, about 2-3 days of chest pain. Young lady, 42 years, she's a model. She doesn't want to have any procedure, any permanent thing. Diabetic for almost 9 years, ejection fraction preserved, single vessel coronary artery disease, this distal subtotal occlusion in the RCA. The treadmill was positive, and you know how these days we all treat. It's pretty standard. Angiogram, imaging, pre-analysis of the length, diameter, as well as what the plaque is made of, and plaque modification. Then implant the device, post-implant, post-dilatation with an NC balloon, and then again an imaging, and then you conclude. What is important is, unlike a metal DES, the scaffold, when you are using BRS, you have to size the distal vessel diameter. You have to take the scaffold size has to match to the distal diameter of the vessel, not the proximal diameter, because you cannot overexpand beyond certain limit. So that's the difference. But when you're doing a metal DES, you size it to the distal diameter, but the proximal can always be overexpanded. But when you come to BRS, the size of the BRS has to be to the proximal diameter, not to the distal diameter. So this is the angiogram, RCA almost subtotal occlusion. LCA had some mild disease, and we crossed with actually a CTO wire in her microcatheter and changed to a cyan blue, and then it was pre-dilated 220 NC balloons, and then again with the packaged balloon that comes with the BRS, 2.5 to 10 lineage balloon to get good opening, and then 275 into 15. Subsequently, this is how it looked. It was quite fibrotic and intermittently lipid rich, but no calcium. And as I was trying to explain, it's a very magnified view of the scaffold. You can see these two are those markers, RO markers edge. From there to the end of the balloon is about 1.2 millimeter. From the end of the device to the beginning of the balloon marker is 1 millimeter. But in effect, between these two markers, balloon marker to the scaffold marker is about 1.3 mm. So you should know when you specially overlap them. You can see in this that the balloon marker, the scaffold marker is here. When you oppose two scaffolds, one after the other, this is how you bring them. The balloon marker of the second stent, a second scaffold, has to be on the proximal marker of the scaffold. So when you implant, this is how it sits next to each other. So the gap between them could be less than 1 millimeter. Since it's so close, tissue prolapse is very, very unlikely to happen. So in this case, that's how it's going to sit without much overlap. In this case, we used two scaffolds, one after the other, post-dilated them, and this was the final result. Young lady, ideal patient. And the final OCT clearly demonstrates, you can see here, that beautiful scaffold, large luminal area, hardly any tissue prolapse. That's one great thing about this scaffold. We have not seen much tissue prolapse inside. And quite spherical, not much eccentric. It's quite a good acute performance by the scaffold. So second case, I just wanted to show you another one. Again, where we had to use overlapping scaffolds. Similarly, you can see here, two were overlapped and they were good. The reason to show is you can overlap very decently with good imaging results, and this is how they would look. And maybe this is the overlap segments when imaged after a year. It's just 1 year post-op result. He had come for another lesion. You can see beautifully endothelialized, very well covered. In some areas, the boxes are covered. That means they've started disappearing. Sorry. Then let me show the last. This is a 4-year follow-up image that I would like to show you. Look at this. This is how it had started. And this is 4 years follow-up image of the same segment. Can you look at it? Pristine, golden tube, positive remodeling, and no boxes at all. So I think this has been the endeavor, not to scaffold the vessel permanently, don't leave any foreign body behind, give an option for repeat reintervention, and allow the vessel to regain its vasomotion, and also positive remodeling if that can happen. And that's been possible with this. In conclusion, I think good imaging, the BRS is the way forward. We need to get the best out of this device. Wherever you can't get the best, I think that's where the DS come into play. Thank you.
Thank you. Very interesting, and I'm sure we are going to have some more discussion. So for the case in the box, can we try and finish it in 10 minutes so that we have 5 minutes of discussion? Thank you.
So I've modified the case in the box because no case in the box can be finished in 10 minutes. So I'll have a presentation, step-by-step deployment of the
this thing. And what's a pleasure that between all the people here sitting here, there is more than 1,500 cases of BVS deployed. I don't know where there is a hesitancy. Can you have the timer please changed? Okay, so I will be starting on, I'll just show you the case of a gentleman who came to me about 2 years ago who had a non-ST elevation MI in the inferior wall territory. He has 2 lesions. One is in the proximal RCA, if you can see carefully. Proximal RCA has got a clear-cut lesion, and the second lesion is in the ostium of the PDA, this junction. PLV PDA junction has also got a lesion. So the aim was to give him a final result without any metal. So the lesion was assessed first, multiple views taken, and then pre-dilated the proximal part of the lesion with a 2.5 millimeter balloon. The distal part was also dilated with the 2.5 millimeter NC balloon. After that, this is the post-dilatation picture, and then we did OCT of this thing. Now, this OCT is done without contrast, with only saline into the RCA. The reason for doing the OCT is very clear, that you should know what is the substrate that you're dealing with, where it is fibrous, where it is lipid, or where it is calcific. And once the substrate has been identified, then the dimensions, the length and the breadth of the diameter of the scaffold is done. So this is how the OCT gets analyzed. So you have a 2.61 with the 2.82 distally. As we come for proximally, it's come to 2.24, 2.4, and 0.97 being the tightest area. And distally, it comes to tightest area is 1.76. So you have a spectrum of the vessel that's been cut down to the dimensions. The smallest area is identified. A pre-dilatation balloon is taken because we took that, the distal part was around 3.5, so we took a 3 millimeter pre-dilatation balloon. It was pre-dilated. This is the distal part of the distal PDA part, which also shows the tightest area being about 0.6 and the length of the lesion being about 18 millimeters. So once you've done this, this is our RCA proximal PCI. So we now post-dilate with the balloon that is given. Now, PSP is a very good technique, pre-dilatation done. After that, the BVS is taken. I've taken a 3.5 into 32. It is dilated gently to about 4 atmospheres, held for some time till it gets uniformly filled, and then gradually increased up to, I go up to for the nominal pressures plus a few more, because it does take a little bit of high pressure dilatation. So this is the dilatation you can see. Very slowly, 1, 2, 3, 4. By the time you reach 4, you will find that the whole thing gets dilated well. Then post that, it's done. Okay, after that dilatation is done, you take the post-dilatation balloon and you must dilate. So you can see the result is very good already, but however, you must take the post-dilatation balloon and do the post-dilatation. Once the post-dilatation has been done, in this particular case, we did the post-dilatation. So proximally, when you post-dilate, the distal, the marker of the balloon, the proximal marker of the balloon and the proximal marker of the scaffold should overlap. There should be a little bit of balloon coming into the main vessel, otherwise the ostium of the scaffold doesn't get expanded properly. So please remember that you don't stop well ahead of the marker. You should have your balloon marker and your scaffold marker almost overlapping, tending to go into the main vessel. That is the way you should do it, and do it at nominal pressures. Inside, after that, you can go in and go at higher pressures. But if you don't dilate the ostium of the scaffold well, you can get into trouble while passing anything beyond that. So to keep up the theme of having no metal there, the distal part we did a mosaic as silonymous eluting, drug eluting balloon. So the mosaic and the BVS was the combination. So once that was dilated with the mosaic, we kept there for about a minute, and we got excellent results. This is the final result. You can see that the PD is flowing well. The ostium of the PLV is not compromised. the PD is flowing well, and so is RCA flowing well. So next we do a final shot, and this is the last pullback from the mirrors. So what all you see, this is again a saline pullback. You can see that in this particular case, the apposition is fabulous, and we don't have any areas of thing. This not necessarily be the case in every patient. So imaging is absolutely necessary. We lost a wonderful product, Absorb, because everybody started doing left, right, and center without following the protocol. We don't want that happening with the mirrors. So please follow the protocol. Please image as far as possible. Please don't be overconfident that you've done a fabulous job just by looking at the angio. PSP is a good option, not the best option. So you can see this is the dimensions we got, cross-section pullback. You can see that it's very well opposed. You can see the stent struts. You can see the vessel sizes are significant. This is the 3D, and this is the pull-through. This is fly-through. Fabulous. You can only see the guide wire. You don't see any metal, and you see the corrugations on the vessel wall suggestive of something is there, but you can't see what is there. So that is the first part of this thing. This is the final areas of the RCA that we got. 9.6, 10.06, 10.09, 11.24, 11.61. So that is as massive as the RCA that we got. So I'll just show one more case. That is what everybody has spoken. Dr. Navsundia just said that 1.33. So important to remember that 1.3, and this is how the overlap gets done, as has been explained. The balloon should overlap the deployed stents marker. The balloon marker should overlap the deployed stent marker. Simple logic to go by. So there was another presentation where he had said about the usage of guideliners. Please make sure you take a 7 size guideliner, not a 6 size guideliner. And BVS 3.5 usually doesn't go in a guideliner. So what you should do is that if you're going to take a guideliner for a particular deployment, please load the BVS in the guideliner and then put it into the guide and then go inside. Don't attempt loading the guideliner with the BVS halfway once the guideliner is in position. You may dislodge the BVS. It's happened, that's why I'm telling. So this is the RCA. So I've used, this is an RCA. You have the assessment with the OCT. You can see the dimensions. You should assess every segment independently. Find out what you're dealing with. You should know the morphology, how much of calcium, how much of what is the tightest area, what is the landing zone, what is the takeoff zone. All these things to be analyzed very well. And then you determine the lesion length. In this case, we got a total lesion length of 58.4 millimeters, 3 millimeters distally, and 3.5 millimeters proximally was the diameters. So we took first we took a 3.5 into 3 into 19. Here I used a guideliner. So 3 into 19 went beautifully. 3 into 29 went beautifully with the guideliner. Once that was taken in, then I had to change the guide because 3.5 wouldn't go through the same guideliner. So I had to change it to a 7 French AL guide, and then I went ahead, little deep intubation, and managed to overlap and put the stent. So the overlap again is to be very careful, as Dr. Nasundi has already said, Girish has already said. That's all what you should remember. Now this is what I was trying to stress with the PSP. You see this? So much of floating stills. So if you think that you've done a post-dilatation and you've done a great job, you may be wrong in a lot of cases. You may require a post-dilatation with a higher size balloon than the post-dilatation balloon provided by the mirrors. So you should know that your post-dilatation may not be complete. So this I had to post-dilate all over again. And once I post-dilated, there is a malapposition in the mid-segment which got post-dilated. This is to show you the overlapping area. So the overlapping area just shows a 1 millimeter of increased number of cells. That's all. There is just a 1 millimeter overlap, that like the fingernails overlapping. It is not an overlap like we saw in Dr. Selvamani's Absorb case. It doesn't overlap like this. It just overlaps like a few fingers. That you should know. And then you should post-dilate and make sure that your apposition is very good. Eventually, I got reasonably good apposition. Even then, here I missed a strut that is in the distal most area. Proximal and rest of the areas have been apposed very well. So, to conclude, I would say it's a fabulous modality. It's an emerging modality. It's an Indian-made modality. So we should try and follow the rules so that at the end of the day, we end up with excellent results. Thank you.
Thank you very much. I think this has been one of the most interesting sessions because we have more questions than real answers, because we need to be cautious and we need to be meticulous. You very rightly said. Uh, can I ask all of you, where would you back out of implanting a BVS once having decided or thought about it? Starting from you, Mahesh.
So, if the bed has not been prepared well, I will avoid a BVS at any cost. Because I will not be able to get a good result. I will not be able to post dilate to the extent with the OPN NC balloon like I would like to. So, if the bed preparation is good, I would go ahead with the BVS. Extremely tortuous arteries also I would try and avoid. You said I've already committed. Then if the bed preparation is not good, I'll
Fine.
change.
You made your point. Girish?
I think for me, it depends on whether deliverability of the scaffold, because sometimes even if I'm not able to post dilate, I will accept it like probably a DCB. But the greatest challenge is if I take it in and I cannot bring it out. It does happen in tortuous, not well prepared, as Dr. Mahesh said, or a calcific nodule.
More
where-
chances of slippage.
Yeah, the blood, I mean, the scaffold slipping off the balloon. I'd be scared of that. Otherwise, I think we can do.
Okay, so I mean, if you see that you are having some difficulty in going ahead, you would like to back off at the initial stage?
Absolutely. This is not a stent. This
Yeah.
is a polymer crimped on a balloon.
So the tactile feeling is important. If at the entry point you are facing some difficulty, either we should be prepared for some more heroics or probably back off.
Yeah, I mean,
Gautam, you have anything to say?
See, as Dr. Girish has mentioned that we should basically discriminate this, like it is a scaffold, not an stand. So the thing is, you should prepare a good bed, number one, osteal positioning.
What has been said, anything in addition?
Yes,
Because-
so then if you feel like you are doing a osteal positioning, it is not proper positioning. If you are thinking that you might need a bifurcation, it is not a good choice.
I don't think we are going to outcome in the long run in that particular patient. Suppose I ask you what would be the one time where you would like to do the OCT. So Gautam, you can start from that.
So it is mentioned
One time.
one time. I think the 1 year follow up. After 1 year, you should
1
like
year.
to check. Yes.
Okay, fine. Ajay?
If patient is symptomatic, I'll do it as early as possible. But if patient is, I'll take 2 years time.
You will
Because
take
see-
2 years.
Because it says 2 to 3 years. I
It's
want
not
to
a
see
geometric progression. You can say whatever you want.
I will do it after implanting, immediately after implanting. That's the one single best chance that I have.
Yeah. You'd like to make sure that it has been done properly because that is the most good indicator.
Absolutely.
Mahesh, anything else? You,
Immediately after stent deployment to look for any malposition.
yeah, I think both of you have a point that if you have seen that it's well implanted, then it's going to work, unless there is something really very, very unusual there. But 1 year perhaps I think would be too, because you are
So,
neither here nor there.
I will do it immediately after, like Girish said. Any other follow-up, I'll do a CT scan.
Yeah, that's a good thing, right? Absolutely. Yeah, because CT will show you the lumen and the pointers. Yeah, please.
So the earlier generation scaffolds had these problems with the recoil. Can any one of you or all of you share your thoughts about that on this new generation scaffold?
If you go by the product information, it says less than 2% recoil on bench testing. But in real life, I think we know that depends on the bed preparation. Why imaging is so crucial, more so on OCT than IVUS, is when you really prep the vessel, the lesion, you have to do another run before you take the device in. This is not just another metal that you can thin strut, you can push and pull. and use an OPN or an IVL after implanting. There is no scope for all of that.
So simple thing is wait for a couple of minutes, see for any acute.
But to put a
Put a metallic disc.
sensor.
Yeah, and that's its second solution is also not a bad one. Yeah.
And one suggestion, sir, just be prepared that there is going to be malapposition of that metal stent because there's a BRS behind which 100 micron, and vessel is going to probably positively remodel. Next time when you try to recross the wire into that metal stent, we should be mindful that it may go through the beyond the stent struts.
Now, in the listed advantages, we know it's remodeling and this and that, no, is late stent thrombosis. There is also vasomotion, but that has not really been studied in long term, if my knowledge is up to date. Any studies which are studying the vasomotion after 2 years or so?
So studying the vasomotion is the most difficult thing to do in coronaries.
Not standardized also.
Not standardized, and all the drugs you give to study the vasomotion can cause cardiac arrest and death. I don't know of any studies, and I don't recommend that. We should, we should be happy with the golden tube.
It's just presumed.
Yeah, presumed.
And I can't say, because that's what I wanted to ask all of you. Any studies you know of? No.
One more suggestion is, in very obese patients, visualizing the thin struts of the newer biovascular scaffolds, any difficulties?
Right?
No, positioning the stent, whether there will be any difficulties?
No, not really. It's just like any other thing. You just need to be sort of aware of the pointers and the dots and whatnot, where exactly. You need to be very sure of your proximal and distal landing points. That's important. You need to be sure, have a good image on the side, and then only do that.
You could be a little more longer because knowing that it will disappear, but be precise. Start from healthy to healthy. And as Dr. Mahesh said, please post-dilate, being mindful of where the scaffold ends, not on the marker, maybe another millimeter.
Thank you for an excellent session, and I think all of us have learnt a lot, especially me. Yeah, please, we have Ramakrishnan here as the opening batsman. Hari Kishan, please. I think we can start and let the others trickle in, because otherwise we will not have that much time. So, please go ahead.
Good evening, respected chairperson.
Sorry, Dr. Kaul is there, Dr. Upendra Kaul. Rakesh, Dr. Nitish, you didn't see them. Okay. Okay, they will come in.
Thank you, respected chairperson and dear friends. I think I just want to individually ask you, like, why people are sitting here? Like, are you seriously interested in writing a grant, or you just don't want to move out of this hall? Okay. So what about writing a grant in Indian cardiology? This is not a common thing, but the most important message is start when you are young. That is the critical thing. So the basic problem, why are we in this situation? Why are we in this situation? Maybe Dr. Kaul is joining us, so sir, you can come over. So why are you in this situation? Clinical research and publication, it's not so attractive among the young generation. Is it real? Is it a real thing? Or is it we are always making this? That's the first question that I want to answer. So is it, or is it one of those IMT syndrome? What is this IMT syndrome? is in my times. So we all have this, like different, we always compare it with the previous generation. Oh, in my times we used to do this, in my times we used to do this. So this is one of those in my time syndromes. So what are the features of this in my syndrome? It is more common after 50 years of age. You just tend to forget the past and you compare your best with the average or the worst of the other generation, and you forget the vast nature of the specialty in current times. So none of the things that we were talking about, all those things are not there at all. And many RCTs and procedures are non-existent. So now you cannot no longer publish a case report or case series of say, okay, I've done so many, one procedure and then publish it and move on. So those kind of things are not there. So I say that I'm not here to preach, but everybody who does it always does the same thing. So for this part of another meeting, then I did a small survey of all Indian pediatric cardiologists, what is the number of years and number of publication in Indus journals, and number of projects they have done. So categories into 3 categories, 69 responses in pediatric cardiology is very good. So this is actually the number of people responded and the average number of publications. So the most important point is you compare it the years of experience per year experience, it was nearly the same. So I think it's not that we cannot just blame the young generation. So they are also doing possibly the same number of publications per year as compared to the olden golden generation. So I'm here to vouch for the younger people who are sitting in the crowd. So it's always a very difficult thing to compare between eras, but eras are very different. So one important thing is possibly the jury is still out. So for example, when I compare it in AIMS, out of the nearly 40 odd residents who are there, only 8 people have published, and out of them they have published 18 publications. So the most important thing is I always tell my residents, it is almost like starting beta blocker for heart failure. If you don't start the beta blocker for heart failure before discharge, you are unlikely to ever start them from OPD. Same thing happens in projects and publication. When you're doing your residency, you don't write a project, a reasonably good project for worthy of funding. If you don't write a paper, you are unlikely to do it in your practice. So that is the most important thing that I always say. So why is it so? Because there is hardly any incentive. So it is people don't even bother about H index. So I think people get a bigger platform, bigger podiums with hardly any publications. What matters? Why it matters? Nobody is bothered. So once upon a time, I asked the people of my pass-out party, in one of the pass-out parties, among one of the most intelligent group of residents who are passing out, I asked a simple question: who you think is the most well-published cardiologist in the country? I don't want to name those names because it's an open forum, but the names will surprise you. So it's such a thing. So nobody, even the people who are intelligent, who are following academics, they are also not bothered about who is the most well-published cardiologist. So that is why people are not willing to do this thing. So it is not a necessity for any of us, for our professional life or personal thing. It should bring visibility, but I think it hardly brings visibility. The visibility here is given by the numbers and the industry support that you are able to garner. So that is what gives you visibility. These are not working in India. So in India, what works is not publish or perish, but PCI or perish is what works in Indian cardiology. So this is the fundamental difference why we don't bother about research. And these are the various things. This is by Dr. Prabhakar, that in one of the slides he said is why Indians are not good at art of publishing. So that is what should be the driving force, but unfortunately it is not. We need to improve this. How do you improve it? We have to incentivize research, we have to glamorize research, we have to really appreciate and recognize, and then important thing is mentorship and team culture. These are the fundamental things. And the most important thing is catch them. I'm really happy to see at least 10 people are interested in research who want to learn something from this. So how to improve, how to initiate a grant proposal? The most important thing is the question that you want to answer. So it takes a lot of effort to do a good, well-organized study. It takes a lot of effort. Is it worth it? It should be absolutely worth it. So you should beforehand do a thorough literature search. It should not be a research. And you should always be sure why on earth you should be doing it. So is it really you are passionate about the subject, or you really want to answer that question? That's very important. Because what happens is once you start a project, your enthusiasm is high, but then it keeps on dragging, and ultimately you end up pushing it somehow to finish it. Half the time you don't finish it. So that is the problem.
So the most important thing for any funded grant proposal is the question. Question is fundamental. So always try to have one question, one primary endpoint, and one answer. That's what a good study should look for. We are not here to answer the whole field in one research. That should never be our aim. But that is how we start with, whenever we start. So for that question, is whatever you are proposing, is it the correct method? And is it adequate to answer the question? Or are you absolutely sure that your study has enough power? So the problem is putting too much into one project makes it less compelling, it makes it a salami science. So the next important question is whether you will be able to answer it in a single center fashion or you need a multi-center trial for this, and what will be the realistic amount of funding and timing that is needed. And now the most important thing is which funding agency you should target. So the most important thing, how do you decide about which funding agency you want to target, should be the scope and the format of the funding that is happening from that institution. So every funding agency has a scope to support. So for example, DBT, that's Department of Biotechnology, supports one type of research. DST supports one type of research. ICMR is more open, it supports a lot of research. These are the three most common funding agencies for medical professionals in India. So you have to know the format and the scope. The most important thing that determines whether the funding is going to be successful or not is you and your team. That's the key thing, and the quality of your project and the funding agency's history. So that is what really gets you. The most important thing is you should be guided by your mentors and seniors. And you should always try to make it impactful, not always search for something that is impact factorful. So most of the things that are impactful will ultimately end up being impact factorful. So otherwise it will end up being a wasted effort and time. So the important thing that you need to understand is whenever your grant proposal, the three important headings that even ICMR and everybody started following is whether it's a discovery research, whether it's a developmental research, whether it's a delivery research. So all your grant proposal in today's time have to fall into any one of these categories, and you should be very well focused. So the ICMR is the primary funding agencies for most of this research. The various categories that currently it is offering is for extramural grant is the small single center initiated, single investigator trial. That's the early grant. Then you have the intermediate grant, and you have the large grants, that's a multicentric trial grants, which runs up to say around 8 crores. The first one is roughly around 1 crore grant. That is current status of the grants. Then if you have interest in one particular group of thing, if you are an advanced research, you have done some research in that field, then you can start applying for Center for Advanced Research, where you can put together a group of projects like Dr. Hari Krishnan has done in heart failure. We got a grant for pulmonary hypertension. So you club projects together and get a grant that is known as Center for Advanced Research. Then you have Center for Coordinating Excellence. And then there are specific calls that are made for, say, women disease and various other things keep on coming from time to time. So those things you should be ready for. And then the DST is a very important thing. The youngsters, you should always known as the SERP protocol for Young Investigators Grant. That's a very easy to get grant, and it's a very good first grant that you should always go for. It's quite simple to get, and it's a minimal funding, easy to manage to start with your grant proposals. And then there are a lot of innovation grants, I think, for new development of catheters and new development of devices. I think Sri Chitra has a pedigree of developing such thing with DST support. Then you have DBT grants. DBT particularly funds some of the projects that are actually biotechnology oriented. They fund it. And then CSIR, you can get something that is industry driven. But if you come to international grant, the most important grant that we should be aware of is the Wellcome Trust grant. They give early career, intermediate career, and advanced career grants. And then they always have their focus areas like infections and vaccines. Other sources always industries, especially the newer devices, newer technologies. I think industry-driven grants are there. So once you identified the funding agency, the next important thing is what should be the deadlines, because many of them can be open-ended, like, okay, you can keep on submitting year-wise, you can keep on submitting, but most of the grants have a specified deadline. So 30th April will be the last date for a particular type of grant. You should be prepared, we should be prepared well in advance. It's better to prepare 1 year in advance. So most of these have a fixed time next year. So always start preparing 1 year in advance so that you have plenty of time to prepare. And always make sure that you are eligible and your project will fit into the category that you are choosing to apply for. And always try to gather almost all the information that you need to gather about the particular grant type. Then you ask the mentors. But the unfortunate problem is you don't find many mentors across India who have done big projects and big funded projects across this thing. For example, in the last set of grants that were released, not even 10 people have got grants from ICMR, all the grants put together in cardiology. So that is the reality. So most important thing is the rationale has to be rational. And your experience, your collaboration to research and career development and autonomy are very, very key features that are very important. So the two key things that anybody who is going to review your research proposal, grant proposal, whether it should be funded or not, is it the same old wine in a new bottle, or is it you are really thinking of some new idea? And the other important question is, will you be in a position to deliver it, or will your team will be in a position to deliver it? Nowadays, it is becoming extremely highly competitive. So you put an ICMR grant, you are competing with the same guys who are doing biochemical research. They are doing only research. We are clinicians who are taking care of patients, we are teaching, we are doing research. We are actually competing with them. So in getting the proposal. So you have to be very careful. It has to be a competitive proposal. It has to be quality and feasibility should be there. You should always be prepared about pitfalls and contingencies. The timeline has to be realistic. That's most often the reason why it gets rejected. Some of the good proposals get rejected because the timelines are unrealistic. And the team should be good enough. And then creativity has to be there. And you should be knowledgeable, your team should be knowledgeable. And team is very important. Just because, okay, by putting Dr. Kaul's name, you will get the projects. It doesn't work out. The people who are sitting there know whether that project needs him or not. So that is very important. You cannot, because these have gone through everybody. So the review of literature is very important, what is known, and you should always build upon that, and you should avoid research. And when it comes to particularly writing, the title should be really compelling, simple and precise. It should be explicit, and you should follow the guideline, always give a brief title. And always start with the outline first, and then plan multiple drafts. You start with your methods, stats, and budget, and then for more analysis. This is a very important part, is that some of them first ask you for one page synopsis or 300 word synopsis. That's the most difficult part. You have to just compress them into one go and then give it together. The method is everything. You should really plan it out very well. Should be able to reproduce. It should be clear. It should be detailed. Ethical approval. It should be all regulatory approval. You should have thought about it. DGCA, whether will approve or not, what is the status and all those things. So the most important thing is whenever it comes after review, always attend to it. Always take it in the right spirits. So you might get nasty comments. Don't go after them. It's a thankless job that reviewers are doing. You should do that. So even if it is getting rejected, always you have done a good job. So if it was reviewed by somebody and given at this thing, you should be very happy. So you should always follow the 3 journal rule that always start from the top and go to the next level funding, and then this is for publication, but that holds true for a project, because after submitting it 3 times, most of the time we lose our hope. So I think we should follow this simple principle to start good writing. I think a good grant proposal, you should always be able to get it through. So hope you enjoyed them. Thank you. So these are the major projects that we are doing. So I'm the PA of Mission Delhi, STEMI Act, and now we are starting an ambitious 12-center study of latecomers with STEMI, a randomized control trial, and they got a grant for PH. Thank you.
Yeah. I just had one request, Dr. Ramakrishna. If you could online suggest the cardiologist, what are the topics that can be researched on? I think 50 topics people can choose, because most of them do not know what to do. Thank you.
I think it will all depend upon what is your research interest. If you want to get into heart failure, or you want to get into complex PCI, or you want to get into antiplatelet agents, so you have to first choose what is your interest. And out of that interest, then you review the literature, see what are the lacunae, where there is a controversy, is a debate going on, and then you choose a subject in which, you might get a solution, some kind of an answer. I think that's the way one has to go about it. I think I'll request Dr. Hari how to build a portfolio. Why should I give you research protocol? What is your background? How to build that, so that you get it.
So how to build a research portfolio and collaborations. So basically selecting an area of work, as somebody has suggested, and how to build a research portfolio, importance of teamwork, how to build up collaborations, how to expand, but still keep being focused. So What I will do is we have developed some collaboration and some work on heart failure. So basically I will be discussing based on that. Don't think it otherwise, because I thought we will be discussing better. It will be taken if it is discussed based on a background which we have done. So when we identify a research area, for example, it should be novel, uncharted, conceptually significant, feasible and simple, if possible, think for a long-term plan, chance of getting funded and reasonable potential for expanding to research to a higher level, potential for collaboration, etc. that we have to think about. For example, heart failure or pulmonary hypertension, as Rama has suggested. So I will discuss the journey where we have done on heart failure. We started with a small registry in Trivandrum, then we escalated it to Kerala, then India. Then we have the National Center of Excellence, and how we did the collaborative research. So when we identified heart failure, it was actually not by choice, it was by accident. We can say that, but the choice selection was not bad, because when we started in 2011, heart failure, there was no data from India. It was relevant to the country because India has a high CVD burden. Heart failure, we know that it is clinical and social relevance, for potential for collaboration and chance of getting funded. So we started with our hospital, wanted to start a transplant program, and we applied for a comprehensive heart failure management program. We know that it will not get funded, so we added the registry as a component of that, and within 2 months we got the funding for 58 lakhs from ICMR. They started the first collaboration. So to start a collaboration, it was difficult. We approached all the hospitals in Trivandrum. Fortunately, all the 13 hospitals in the Trivandrum city who admit heart failure patients joined together, and we identified a rural area also, 5 hospitals including PHCs from that region, and we had a protocol. We sat together and developed a protocol, and we collected the data in 1 year time, 1,205 patients. So the problem was to get accurate data. If you ask me about any study, the data is the most important. Without good, accurate data, the study will not progress. So to maintain the collaboration, initially there was significant enthusiasm, but how to maintain that collaboration, that was the most important thing. So we had periodic newsletters. There were issues from the primary health centers. Doctors were changing, frequent change of managers, lack of proper address from patients to contact them. Then all those problems were there. But fortunately for us, at the end, we got a very good data, 1,205 patients. What we found was, for the first time from India, 10 to 15 years younger patients, 80% did not receive the guideline-directed therapy and high mortality compared to others. This was presented in the late-breaking session in European Journal of Heart Failure, Acute Heart Failure World Congress. And the same day it was published in European Journal of Heart Failure. So we were very happy. And we continued that collaboration. We converted it into a Trivandrum heart failure cohort, continued funding by ICMR, and we have published the 1 year follow-up data with a 30% mortality, 3 year follow-up 45% mortality, and 5 year we have 59% mortality. So probably we can say this is a success because of the collaboration. So how to build a team? That is what I have been asked to discuss on. So participation from the beginning, listen to the team. So you are only one among the team. Even if you are the PA or you are the originator of the idea, share the getting ideas from the team, share and care. That is the way we should we should progress. Sharing the funding opportunity and acknowledging the teamwork, and discuss the publication policy, because publication is the outcome of your research. So discuss it from the beginning itself. What are the publications you are going to, the other people are going to get. And there should be no ego when you conduct a team collaborative research. So the output of a research is a collaboration of all these things, like research team, funding agency, administration, regulators, all will join together to form a well-knit research. So communication and collaborations are very, very important. For example, if you see collaborations, identify people we can work along with. Networking during conferences will help. Attending relevant meetings. If you have identified an area like, for example, if you are planning to conduct research on TAVR or something on biovascular scaffold, you network during conferences, identify people who are working on this, and communicate with the people in the field. For example, if you see some publication on MERIS or some biovascular scaffold, you contact the person, send a congratulatory note. That is how you build a collaboration. And learn from others' mistakes, and sometimes you may get additional expertise, manpower, fellows. We got a fellow from Duke University, USA, who analyzed our 3 year follow-up data and published. She had also another 2 or 3 publications with us. Who are the right collaborators? That is the next question. Expert that bring some other expertise. For example, as cardiologists, we have very little expertise in analyzing the data. So if you have somebody in your team who can analyze data, give some form of analysis, that will be great. Then data management and analysis, that is what I said. Then who have already experience in this particular field, then all those, and interdisciplinary project will be, if you are writing a new, looking at a new area, interdisciplinary concepts will be much more accepted. So stay up to date in the area. That is also very, very important. If you are selected a particular field, it is important to stay up to date. So what you can do is you can register in the PubMed. For example, if you have done on TAVR, you can register TAVR and give your name. Every Saturday, you will get all the published data or the published articles on that particular topic. So you have started this thing and you are partly successful. How to go to the next level? That is the most important. You can do it in 2 ways. You can expand the footprint. For example, you have done a 100 patients research, you can make it 500. Or you have done a local network or local registry, you can expand it to a state registry or a national registry. Or you can expand to the research to related areas. For example, you can start on basic science research, etc. So observational studies, increase the numbers or increasing the footprint. Diversify your related fields. For example, you can do implementation research or policy research for bench to bedside. For example, you can develop a device for a particular area. For example, in heart failure, we are developing the NT-proBNP device, or it can be an idea to prototype. So what in our case, we did the Kerala Heart Failure Registry. So we didn't stop at the registry, we also did a quality improvement as an addition, as an implementation research. And this was the result. Again, another late-breaking publication in American Heart Association. We published the article in the European Heart Journal, prestigious journal, and Dr. Stigi was the PI. And then we ventured into the National Heart Failure Registry with a funding of 2.87 crores. This is the larger collaboration at a national level. You can see all the red stars are the major collaborators like AIMS Delhi, PGI Chandigarh, Jayadeva, and PGI, Jibbar Pondicherry, all those major institutes joined together, and we have this the largest registry from India. Again, another late-breaking session presentation in European Society, and we published the 10,850 pages, still the largest heart failure registry from India. And how to expand the research area, identify the related fields, not to go too far from the main research agenda, venture only if you have good collaborators, and interdisciplinary research. That is what we did in our second part when we got the ICMR Center of Excellence, where we, with this background of this National Heart Failure Registry, we got this. We joined together with many other centers like Rajiv Gandhi Center, NITs for interdisciplinary research. And what we have achieved is that we have the national heart failure data of around 30,000 patients. This is the collaboration of all the people in that region. That is how you two build collaborations. We started the biobank and the genetic studies. We are just going to publish a study on economic impact of heart failure from 20 different centers from different states. Then we have a device development, all those things. This is the first heart failure biobank which we have created, 3,500 biosamples, first in the country. The genetic studies on hypertrophic cardiomyopathy, we have also developed the quality of life measurement tools in India. This is a collaborative research from different people. One institute or one person cannot do this. This is a collaborative effort of people. And for this biomedical device development, for this NT-proBNP device, we are collaborating with the Rajiv Gandhi Center for Biotechnology. And this is another area which we have started collaborating. This is a meeting called Heart Failure Conflex, which is a meeting place for the basic scientists in heart failure and the heart failure cardiologist. It's a very, the meeting has gained very significant importance, and now last year we got around 40 abstracts from all the major institutes in the country who is doing cardiovascular research. Based on this, we have part of many collaborations. You can see in guidelines, writing a short paper on charting a roadmap for heart failure in India, some international collaborations also. So what are the challenges in building collaborations? Very few are interested in research. As Rama has pointed out, hard to find co-researchers. All are engaged in clinical work. Very difficult to get. There are good people who are interested, but to join together them is very, because it is not rewarding the term of finances. Collaborating with another institution, especially government institutions, MOUs, permissions are all a problem. Apprehension, what will be the outcome? How will I get any publication? Will the data be shared? So you should have a protocol from the beginning itself before starting. That is the most important thing to do, to clarify the things from the beginning itself, to have a publication policy that first paper will be presented by the host institute. Subsequent papers will be depending upon the number of people recruited, like that. Data quality, that is the most important thing, and make sure from the beginning that you have good data quality. Without good data, you cannot do good research. Because if one center is having a problem, it will affect the collaborative approach. So when you select the collaborators, you should identify the people who you can work with and who are reliable. So publications, sometimes to get you had sent a publication somewhere and they have sent the comments. To get comments from the collaborators are also sometimes even difficult. So how to overcome these challenges, to have a rapport with the team, have a personal touch. We consider them as all among equals. That is the best way. Periodic online and in-person meetings are also helpful. And authorship in publications and presentations in the conference, involve them and make them part of that and make them do most of the things. So to conclude, how to build a collaboration, and the first thing is to identify a suitable research area, build it up slowly and steadily. It will take time, be patient. Teamwork and collaboration is the most important, as I have said. Don't get stagnant, improvise and expand. Stick to one area, but expand it wisely. We know that uncharted areas may give better prospects, but it is very difficult. In research, always aim high, you will reach a reasonable level. Thank you.
Thank you very much, Hari. It's always, many people start a research project and they're very keen to begin it, have some collaborations. But as you go along, you have to recruit a particular number of patients, you have to follow them up, you have to, bring their investigations in time. And that is sometimes a hard task. So what are the, what are the bottlenecks which come in? So I think Ajay Mahajan is going to tell us about what are the bottlenecks which we face in our day-to-day research. I am at present conducting a 75-center research protocol. And it's so difficult to, keep interest going. In the beginning, they are very happy. They go on recruiting. But then once 50% have been done, they get involved here and there, and keeping them in track, bringing them back in time is always very difficult. So you're going to tell us what all are you facing and how do you handle it and how do you advise us?
Good evening. My sincere thanks to Professor Dr. Upendra Kaul sir for giving me this opportunity. So this is a very philosophical topic. So coming to the cardiovascular research in this world. So everything started on 12th April 1945. On that particular day, that time's most popular US president, that is Mr. Franklin D. Roosevelt, he died because of icy bleed, and at the time his blood pressure found that these cardiovascular diseases are increasing, and the vice president became president. He used atomic bomb. There are multiple problems which happened because of cognitive imbalance of Franklin D. Roosevelt. And subsequently the Framingham heart study was started, and it was the largest study. It was started where 15,000 participants, 3 generations, 6 decades, and subsequently that study, the finding study, had shaped the understanding of risk factors of cardiovascular disease. It had also been instrumented in promoting the prevalence of cardiology, preventive cardiology in modern practice. However, it is important to note that first result of Framingham heart study was published after 13 years of recruitment of first patient. And the most important thing is that quality research, static nature of population, no immigration, electronic health records were enabled for easy data collection and analysis. And the data which was collected was very authentic data, and it was very aggressive collection of the data of all those recruiters with their subsequent generations. So can the Framingham diseases of India, cardiovascular diseases and other NCDs which are also related to the CVDs are around 28 plus 12. That is 40% of population die because of CVS. The India has been rapid transition of the disease burden. Now communicable diseases are going down because of they are absolutely at a multiple at a district levels, and we can collaborate with them to get a data collection and research. Then enormous scope and interest building capacity in clinical research is also possible. The presence of regulatory authority governing the clinical research is there in India, and there is a large pharma industry. The India is the country where absence of centralized data record and electronic medical records. That is the very important thing. If you make this particular thing, EMRs should be made mandatory and universal for pan-India, then it is very easy to get a demographic data of about all diseases and all patient population. There is a shortage of adequately trained manpower like specialists, nurses and technicians for cardiology practice and research at district levels and periphery and at a rural level. The lack of awareness, dedication and motivation, that is the most important thing for the research in most tertiary care institute and public, and that is always there in public and private. So the awareness and dedication, it comes with the person and not with the force. So if you see the data keeping in our institute, so different institute in BMC, we are having a different kind of sets to write a data, and ultimately it is a wastage of time to keep a data like that. But if you keep this data electronically, then it is very easy to analyze that particular data in future and make some scientific deductions from the particular data collection. Coming to the feasibility, the lack of adequate government funding has pushed the commercial research organization as a major source of clinical research, and which may give a biased result. Then low level of education amongst Indian patients threatens the informed consent process. So most of the time when we talk with the patient for the recruitment in the clinical trial, there is a taboo. When they read about the consent, then they may go away from participating that particular trial. So that should come in the primary education or high school education in the textbooks, that all these clinical trials related thing, consenting, and that particular thing is for a national importance and getting a data nationally, and that should be inculcated in the all population at a younger age group. Then one other most important problem is the overburdening of the tertiary care hospital with the primary and secondary care. So if you take a tertiary care hospital, most of the time they are primary care hospital for the patients who are there in their vicinity. Though it might be a institute of national repute, but you might get a primary care patient or secondary care patient in that particular institute because it is in the proximity of that particular area. And the same thing is happening in our institute, though we are at a tertiary care center, but because of population, overpopulation of Mumbai, so we are getting maximum work we are doing in OPD is a primary and secondary care. Then another important thing is that independent practitioners in community and their contribution in data collection and CV epidemiology study is negligible. So they are busy in their own practice and they don't contribute to the epidemiological studies, and that is also not a good thing. So the regulatory authorities or the licensing authorities make it compulsory for the individual practitioners to contribute to the data collection for the epidemiological studies. Then comes the finances. The lack of government funding for cardiovascular research, especially for the new drug and new drug discovery and production, because of that, sometimes it is not possible to find out some new protocols for the treatment of diseases. The India spent only 4.9% of its GDP, and maximum GDP which is spent on healthcare is coming from the private sector, and in private sector the research is at a very low level as compared to at a government institute. And most of the funding for the devices and pharmaceutical companies product development is concentrated in private sector, and then they are doing their focus research, and that focus research might not be of useful for the pan-India population or large population based studies. Then coming to the time, that is the most important thing. There is no specific manpower dedicated to the research in most institutes. Thus, the onus of the data keeping and writing is on the clinicians and teaching staff, who also have to take care of patients and academic activities. The most research work is given to the postgraduate students who do not stay associated with the institute for prolonged duration. Thus, there is a discontinuity in long-term data collection and follow-up. Now, with the established risk factors, finding out a new, uncommon and rare risk factors identification needs longer period of follow-up. Like in Framingham heart study, they required around 11 years to find out the first risk factor. The similar thing is possible, and for that particular thing, the researcher should be associated with that particular institute for more duration of time, and his dedication is very important. Then coming to the most important thing, and that is the dedication. There is no replacement for dedication and true interest in research. When these are present, quality research happens even at most busy teaching hospitals. Research, in fact, makes the daily decision and practice easier by addressing simple day-to-day dilemmas. There are innumerable examples of our country who excel in the clinical research and have generated quality data which help to mold guidelines in accordance to the Indian population. So everything comes with the dedication. So some examples in CREATE registry or in Pinnacle India registry, we got a specific India-specific things. The legend Dr. Hari Krishna sir is here. So it is one of the best research in the heart failure management pertaining to our country. Then Dr. Justin Paul is now working very aggressively for the pregnancy and heart diseases. Prevalence of rheumatic heart disease, Dr. Ramakrishna sir is also here for the pulmonary hypertension and other registries coming from the AIMS. And one of the big thing, Dr. Upendra Kaul himself is one of the big researchers who have worked in interventional cardiology with and because of him, the Indian stent companies got international repute. So what is the future? There must be initiative from central and state government in data collection and uniformity in that particular thing. Uniform EMR system in government and civic hospitals all throughout the country. There must be uniform policies governing research all over the country. Standardization of healthcare equipment purchased for quality data. Nationally funded registries and large-scale studies with indirect financial assistance from pharma and device companies through centralized body. Cost-effective analysis to drive policy in CVD management and research regarding each drug intervention, which might give us a good national policy to prescribe particular drug for the treatment of particular condition. Then another important thing is that the concept of indigenous lead breaking trial in our domestic conferences. So somebody had done a research, then he should get a best focus for publication of and for presentation of that particular research in our domestic conferences. Better liaison among the large tertiary care hospital, public and private, and independent practitioners for combined research and standard of care and collection of the epidemiological data. The selection of super specialty courses. So as far as the specialty MBBS and for post-graduation, I am not asking. But for super specialization and promotion, it should be based on quality of research and some publications and your contribution during your post-graduation and publication in the research. Then closer monitoring of the clinical trials, it is also essential, and use of artificial intelligence for record keeping and other technical works. So these are the certain things which might help in improving the roadblocks for getting away from the roadblocks for the research. And with this, I will ask Professor Dr. Upendra Kaul sir to enlighten on this particular subject. Thank you.
So the basic idea of why are we doing cardiac research? Today we are cardiologists, so why are we doing research in cardiology? Basically the idea is how to improve the outcomes of our patients. The basic idea of our work should be how to make their lives better. It's also very well known if a patient is in a research protocol and is on a placebo, the patient does much better anyway because the patient is being counseled all the time. You take all your drugs, and the drug which you are assessing is a combination with other drugs. So a complete treatment is being given to the patient So that is one of the things, is how to improve the outcomes. And we need to focus our area, as one of our friends asked, in what? You have to see whether you want coronary disease, heart failure, arrhythmia, and you have to have a question, research question. Which is what problem do you want to investigate, and then formulate a hypothesis. For that, we have to do a complete literature survey. We have to go through the literature and see the lacunae in the research. Then, what are you going to do? Whether you are going to do a cohort study, a case control study, a cross-sectional study. So you have to be first absolutely clear, what do you want? And once you have decided, you have to write a protocol, a complete protocol, so which you don't have to change every day, so that halfway through the research you find, oh, I should have got this information also, and let us start this. No. Have a protocol, write it up, show it to a senior or an expert, discuss it, and then methodology is very, very important. How do you collect the data? The data has to be reliable, as Hari was saying, that if you don't have a reliable data in your this thing, whatever you conclude, that conclusion cannot be, confirmed. We all talked about the budget. It has to be planned. It has to be planned in advance. A big research project is expensive, so you have to find the funding sources. There are government sources, and we just heard Rama telling how many sources can be there. And then you have to have the research facilities in the center where you're conducting the study. It has to be well equipped. And this is one of the ways in which the center can be well equipped. If you have a research project, you get a lot of equipment for conducting that research protocol. You need to have a principal investigator, and very important to have a research team. You need to identify who all will be interested in that, inculcate interest into them. In a cardiology research project, you have to have good relations with the cardiac surgeon, because if it is a research protocol in which, angioplasty or bypass surgery or some such thing is being done, you need to have very good research nurses, coordinators, data analysts, and then collaborators. So collaboration is extremely important in this. So few of the typical tips for success is that it has to be a multidisciplinary collaboration. As Dr. Hari said that, if you have to go and find out the data from Trivandrum, initially he started from Trivandrum, went into Kerala, you have to have multidisciplinary collaboration, more colleagues, allied specialists, patient-centric approach. Why should the patient give his data till the time he finds that, he's going to be benefited? And you have to be always ethical in research. There are no shortcuts in research. You have to be ethical, go ethically, make sure that whatever you are going to do is benefiting the patient, and continue learning, keep up to the date. Recruitment and retention is a challenge. Data management is a challenge. Regulatory compliance is a challenge, but you have to be very patient, perseverant, and go on continuing that. So that's all I just wanted to conclude with that. Emerging trends which are going to come, as was discussed, is that artificial intelligence, from precision medicine to artificial intelligence, we're changing. It's becoming easier, but one has to first learn how to use this artificial intelligence into, machine learning and other things, into creating a good research protocol and getting the data. So these developments are, I think, poised to revolutionize the diagnosis and treatment in cardiovascular research. So that's what I wanted to conclude with, and I just wanted a few questions to be answered by my friends. Is that, why do you think, Hari, cardiac research is not taking, becoming more and more popular in our country? I've been, giving these talks for the last 10 years, but you find 5 of us or 6 of us sitting there and 5 persons sitting there.
Yeah, the thing is, most of the people are too much preoccupied with the clinical work. That is the most important thing, and you don't have any protected time in institutes like us. We do work out of this research out of passion, and we find time from our family time. We use that time for research because there is no protected time, and that is the most important thing. And there is no incentives unless there are some incentives. We get a one day free in our routine work. Otherwise, it is very hard to conduct research and to get, for example, help in data analysis. All those things are becoming more and more difficult. And nowadays, more and more administrative difficulties from the institutes to get a we have deadlines. Now the government have more and more stricter, and March 31st we have to submit the audited reports. It is very difficult to get in a government setup. So these are all the very difficult things which even though we have the passion to do research, we find it very difficult to do it in the practical sense. That is the most important thing I feel. So comments from Rama
and the importance given to the publication, unless, a person who works hard, a young person who works hard, publishes something, is, appreciated, it's given some due recognition in his promotion. That I think is still, lacking.
So I think neither amount of money that you earn, the amount of recognition that you get, none of them is determined. Even the promotion is not determined. Like if you look at the number that is needed to get into become a professor in All India Institute also, it's pathetic. So I think only Sri Chitra has a real laid down criteria where you end up publishing. And even if once you become a professor, I think you're done. You're done. You don't have to do anything more.
Yeah.
So that's the problem. It's all, whatever we are doing is all because of passion, and we just want to answer a question. But at least 1% of Indian cardiologists should be interested in solving our own problems. Otherwise, we'll be again same thing, importing the data and importing the drugs, importing everything. If your Indian stents can come up, why can't Indian data come up? So that I think we should become passionate. At least the people who are sitting here should take up one project at a time and start working. So that somewhere it has to start. Once the critical mass comes, I think the momentum will start.
Yeah.
Then possibly, then ideally, I think people at the top should really think of incentivizing and glamorizing research. So the Indian doctors should be, at least in some of the conferences, some of the academic conferences, at least research should be promoted. By our own research should be promoted.
And including the names of the persons who have been involved in the research. That's sometimes a very sore point. A lot of work was done by me and my name is not there, or my name is sixth name. So that also, when a person sees his name in a paper, I remember the first paper I published long back, must have been in 79 or 80. I was going to the OPD in GB Pant Hospital, and somebody brought me the journal. Sir, aapka naam hai. The whole day and whole night I was looking at the paper and my first name. So thrilled. So I think giving importance to the persons by publishing their names at appropriate points in, good articles, even if he has done a little bit of work, prompts, you would say, how can I become the first author now? So I think that's very important, that importance is not being given. What do you say?
Well, you said, all of us said very rightly, time and incentive. It is not incentivized. And I still think there are too many regulatory requirements which stifle the process. Suppose even when we got the grants, so much time we had to show the utilization, prepare documents, give reports, and justify, and then the institute research committee would say, you have not done this, you have not done that. So, compared to the Western universities or centers, the researchers in India are not incentivized at all. I don't think you get anything out of it except sort of a satisfaction and, as you said, seeing your name or being recognized in a meeting. But beyond that, we should, you have been CSI president, there have been so many requests that CSI has so much funds, they can incentivize research. I personally don't think anything is happening on that end. I may be wrong.
So two important things that are missing are a research culture and systems for research. Even strong institutions don't have a system for research. So if it is there, if the culture is there, I think the youngsters will automatically follow that and they will take it higher. But unfortunately, they are lacking.
If we talk of data collection, 20 years back, I tried to put the NIC data online. And then I was pulled down and they said, no, this is not going to happen. The website was closed, this and that. So we are not yet we haven't got to to a stage where we can put the data online. Because that time I made the whole portal, tried for a year or two, but then the headquarters pulled us down. So
No,
I
like
mean, we just don't want it.
teaching institutions like PGI, All India Institute here too. Dr. Rama is here. How about giving, time off to some reasonably senior people? 6 months. You come to the hospital, you don't have to go to the OPDs, you do your work. Does it work?
We had a symposium on this, like there was when Dr. Guleria was the director, and he said only one thing. You show me a person who has done very well published, who has done a lot of work, who has bunked his clinical work to do research. So all of them who have all done is done with the passion, and they've taken time out. You show me, he asked me, he asked us, all the people who are sitting there, you tell me one guy who has bunked his clinical work to do research. Most of them are those who are very well published are actually some of the best clinicians around at that time. So I think somehow we have to get that balance right. I think maybe that may be unrealistic, like getting 6 months off, but maybe as sir said, maybe 1 day out of 15 days. But you measure, you give me 1 day off in 15 days, but you ask me what is your output. So that kind of a thing should be the norm. So I think, but still I think we now somehow get this passion into the younger generation.
That's the most important thing.
That's the most important thing.
Passion.
Passion is the most important thing. We need to answer our own questions. So how come we have such a celebratory mood and everybody's putting OCT, everybody's doing all those things, whereas our North Indian rate of revascularization for STEM is 17%. North Indian rate of revascularization is 17% in the whole country, despite cardiology making so much strides. So unless we don't want to address them, then nobody is going to come and address this for you. No industry is going to come forward. You have to address as a community.
Any last word? Hari?
I think it will slowly change, I think.
What are the obstacles you have faced in your heart failure research? In brief.
Basically, the regulatory issues. The funding was from ICMR to meet the deadlines. It is so difficult, and to get different institutes have different issues. Each institute has its own problem. So to collaborate and to get for example, the report from each of them, it is not because of the researchers per se. It is the administrative hurdles which prevent them from getting it. To appoint somebody, you have a lot of challenges in some places. The registry 2.5 years, one institute could not appoint a person. So that is, and the researcher had to find some other source and appoint somebody. So this can happen. That is the most important. I think the staff, there should be separate staff for the projects or research, and they should know what is the importance of that. Then they will change. The things will change for positive things, because now the electronic data management system is coming in most of the part. In Kerala, it is implemented. I think in other parts also it will come. Then you have the national health ID is going to come. Then it is easy to track. I think in another 10 years probably we may have a unified data, and that will solve many of the issues in following up. And we have the Aadhaar number linked data. So I think in another 10 years probably we will have some unified form of data collection will be there in the governmental systems. So that will solve many of the issues, but the research culture has to come from our own colleagues. Then only it will work.
Basically, it has to come from inside. The tools are there. Tools are improving. They're becoming user-friendly. You don't have to, go to libraries and look for pages, and then finally you get that article. That article is missing. We're seeing those changes also. So those things are not there. But till the time we have this burning desire, and number two, this desire is rewarded. It should not be, I have done this. If it should be acknowledged by the institution, yeah. Yes, please.
Yes,
Yeah,
sorry,
go.
Ramesh here, Ramesh
Yeah,
Dagubat.
Ramesh.
Yeah. So, I think actually it should start in the training phase. In the United States, at least, you're not allowed to complete a cardiology fellowship unless you had presented some paper. It may be in a small regional conference or actually national conference, or you have to publish a paper in a journal. So the same thing is actually held responsible for attendings. I can't be a key clinical faculty or teaching faculty unless I have at least 2 papers in a year, for 3 years in a row for a fellow. So if I'm the mentor, I have to have 6 papers out in 3 years of their fellowship, and they have to have 1 paper. So the standards have to be started during the fellowship to encourage research. Otherwise, I think everyone agrees it has to come within. But unless sometimes we have to force it to come out, force them to publish a paper.
I think so. That's very important that, one has to use stick to make sure that they're doing it. Until the time you show that you have done something, it's not just reading an article in the journal club once in a week, that doesn't matter. You have to show and publish. Publish it, in a smaller journal, but do publish. And once a person gets used to writing and publication, it becomes an addiction then, It goes on and on.
So I think many of the youngsters have said through the whole session, so I think whoever is sitting there, I want to give 3 messages like, start early. Start early in your career in cardiology, start early, number 1. Get a correct mentorship group who can really guide you through a project phase and always think big. So doing a small project takes actually the same amount of effort than doing a bigger project comparatively. Doing a bad project actually takes more time and more effort in getting it published. You do a good project, it's very likelihood that it will be easily published. So always spend time in preparation, always think big, and always think properly with a good mentor group and start early. That's a key.
Write an article, send it to a journal, even if it is rejected, there comes 3 pages of comments, and that helps you to improve further, and that's how you go on improving yourself. Next time when you send it, you will not commit those mistakes. So I think we had a useful session. Thank you very much. So I think that's the end of the day for the meeting, or some more sessions?